conference will now be recorded.
Hello, everyone, and welcome to AnCan High Risk, Recurrent, and Advanced Prostate Cancer video chat for Tuesday, January 27, 2026. I'm Len Sierra, and I'll be moderating today with a little help from my fellow moderators, Rick and Dr. John, and all of you, our well-informed attendees. As a reminder, this video chat is for informational purposes only. Nothing contained in this discussion should be construed as medical advice. We want to acknowledge and thank our sponsors, and I hope I'm up to date on this. I have J&J, Myriad Genetics, Novartis, Telix, and Blue Earth Diagnostics.
No Myriad.
No Myriad, okay.
No.
Foundation Medicine anymore?
Foundation medicine. And you can add Foundation Medicine.
Oh, okay. And Foundation Medicine. Thank you very much for your support. All right, we are going to start with, what did I do with that? Oh, there it is. Sorry, I got a lot of papers here. Here we go. So let's go with our first somewhat new person, Ron Sharp.
So I will do, in the interest of time, I'm happy to do a quick synopsis for Ron. Ron, if you don't mind, and you can correct me on anything that I don't say right, but we spent a little bit of time with Ron last night. Ron lives in Regina, Saskatchewan. I don't think we have any other Canadians. I reached out to Alain, but he's teaching a class. So I've put Alain and Ron in connection. Back in April, May, and I didn't ask, I'm not sure what the issues were that got him to this, but he got his PSA tested and it was 38. And he had a biopsy, albeit a blind biopsy without an MRI. And before anybody starts putting their hands up, remember that we're talking Saskatchewan, Canada, and the standard of care is not what it is here. And my apologies, John McPhee. I guess I hadn't written you down. And so, oh, yes, I had. My bad. Great. So we have one Canadian in here with you, Ron, from Toronto. And so he got a biopsy. From what we can gather, from what Ron seemed to think, there were 6 sectors. They took 2 cores in each sector. So there were 12 cores taken. 5 were positive, and 2 of those were 4+3s. No second opinions. Ron he had a meeting with a radiation oncologist. He doesn't really recall talking to a urologist at all, although, as I pointed out to him, the person that did the biopsy had to have been a urologist. But he doesn't remember having any discussions. He didn't like any of the options that were available to him that were presented, which were probably hormone therapy and radiation. And he felt 100%, so he decided not to proceed with any treatment. His PSA had gone from 38 to 48. He was offered a PSMA scan and also, I believe, may have discussed an MRI as well. Hasn't done either. Last night, we said to him, first of all, with a PSA of 48, he's high risk, so he shouldn't even be in low intermediate. And then secondly, he ought to call this morning and get that PSMA scheduled right away. And like I say, I connected him with Alain, and John, I would have connected in with you too, but obviously I didn't think about it. I apologize. And he's here with us today. And I will let Ron add anything I missed, and we can talk to him about being asymptomatic and what this all means.
Yeah, I think you've got everything, Kurt, there. I have not scheduled a PSMA yet. I can travel to Saskatoon, Saskatchewan, for that about 2 hours away. And my local GP is just tracking me so far. But going back to last summer, it, I did really not want to go into any treatment, and my doctors didn't really advise that that was wise. But I was fairly emphatic that I wanted to leave things for the time being. And I know that July is quite a few months away from where we're at today. And yeah, as mentioned last night, I'm feeling fine, and I'm aware of the side effects of ADT and radiation therapy and all that sort of thing. And I don't know, maybe what I'm doing is not that wise. I guess I've got a faith background, and I guess if my time comes earlier, maybe so be it. And of course, nobody can put a date on if I just leave things alone and let nature take its course. If that's going to be sped up or not, I really don't know. So that's kind of where I'm at. And I don't know if anybody else in does the things that I do, that just let things progress without treatment. So that's where I'm at right now.
Mm-hmm. And did you say you did reach out to the doctor this morning for the scan, or you didn't?
I have not yet. No.
No, you have not yet. Okay. I'm going to make an executive decision here, Len. And the person I'd like to talk to you first, because probably he's got more experience than any of us in this discussion, is Dr. Paul. Because Dr. Paul himself is a peer, metastatic cancer, metastatic prostate cancer. He's also a very senior urological oncologist who was president of the AUA at one point, Ron.
Okay.
And I suspect that Dr. Paul's had to have more discussions like this than we've had hot dinners. So I think Dr. Paul can probably help us out big time here, and then we can take it from there. Do you mind, Dr. Paul?
No, I'd like to ask Ron a couple of questions. One, how old are you, and what's your health like, and what's your family history? How old are you?
I'm 69 years old. My health is good. I do a lot of biking in the summertime. I'm athletic. I only weigh 129 pounds, 128, but I've been that way most of my life. Yeah, summertime, I'm very active. Wintertime, not so much. Yeah.
And your father, your uncles?
I had a father that had colon cancer probably 25 years ago. And I'm aware maybe I should go for genetic testing like the somatic or germline, whatever. I've not done those things, but
yeah. Brothers?
No siblings, no.
Okay. Mother lived to a good old age?
Yes, my mother lived to 93 years old.
And no family history of malignancy, and you're healthy and you're 69, and your life expectancy probably is another 15 plus years, considering what you've just told me. So I'd be very concerned in understanding that you're the captain of your boat, and you seem to be pretty focused on, we'll say, letting life and nature take its course. I think I would, through further discussion, some reading, bring to the fore that this could be a threat, a significant threat to your well-being into the future, and want to learn more about the disease from the scans that have been suggested to you. I can say that if they show spread, which I hope they don't, but if they do, that kind of pushes more towards some treatment option. If there is no spread, it would be very difficult for me to say my advice is to leave well enough alone, because you do have a rising PSA that's kind of escalating, and it's way above anything we'd want to just presume is okay. And you do have 4+3 Gleason pattern 4. Would like to get another view of the microscopic analysis, because there may be something about that 4 that's even more concern. So you hear from me a recognition of you're the captain of your ship, but my concern that your ship may be in danger, and I want to learn more and kind of stick with your educational approach to prostate cancer.
Okay, thank you.
Great summary there, Dr. Paul. Thank you for that. Now, sorry. This is, we're talking with Ron still, right? So, Ron, do you, as Paul mentioned, you certainly have the right to live your life on your own terms. But what about other people? Do other people depend upon you? Have you talked with people who are close to you and how they might feel about your leaving this earth earlier than necessary?
I live with my wife. I have 2 growing daughters. I've got 5 grandchildren. They're aware of my take on all this. My wife came with me to both my appointment last summer. I've only seen the oncologist once. I went to see my GP here about 2 months ago. He spent probably an hour and a half with me at the end of his day talking to me about this. And he said he would follow my wishes. As I said, he didn't really agree with what I was doing, but he said he would order whatever tests that he could from a GP's point of view anyways. So yeah, and as I said, I guess my philosophy through life is I've read a lot about cancers from way back. I'm aware that some nutritional approaches and the way of eating, even your stresses in life can contribute to all that. But yet I know there's the findings of PSA testing and all that sort of thing. If the cancer escapes the capsule of the prostate, then you're looking at a different scenario. So I'm aware of those. So, and I don't know of anybody that's taken kind of the approach that I have, like, let's just let this thing kind of run its course.
So we've seen that, Ron, over the years. We've seen people who do want to let it run its course. And to put it bluntly, it's not pretty, because unfortunately, prostate cancer is not easy on you as it metastasizes. It can be painful and difficult. And frankly, if for men who choose not to follow the standard of care, the results are not good. In fact, I heard this morning of a gent who attended a Canadian in British Columbia who attended our groups a few times, and he would not consider chemotherapy. He died yesterday, probably a good few years earlier than he would have done if he would have listened to some of the navigation advice we'd given him here. So, of course, you're free to choose, and we respect your faith. But the problem is, even though you feel 100% right now, and most of the guys will tell you when they were diagnosed, they also felt few were symptomatic, but not that many. But most people felt fine. But if you don't act on it, then you're going to be facing, I don't say you are going to be facing, but it's highly likely that it's going to be very symptomatic before too long and not pleasant. And that's what you have to weigh up. It's not going to be like this all the time. We have a couple of hands up, Len. Let's see what.
Yeah.
I have to say.
Yes, we do. Lee Balin, go ahead.
Yeah, Ron, I was faced with your decision 10 years ago, looked at all the side effects, and I decided to go for treatment. In the last 10 years, I've been on ADT, 8 years of it. I had 40 radiation treatments. Side effects are not pleasant. They can be brutal, but life goes on. And in that 10 years, I've welcomed and loved 3 new grandchildren added to my 4 that I already had. We travel regularly to see them. We've traveled the world. I've been to Europe 3 times. I've been to the Galapagos. I've been to Machu Picchu. All of that after ADT and radiation. Life goes on, and it can be a truly fulfilling and loving life. You have grandchildren. Live for them.
All right, Lee, thank you.
Could I just
Russell,
ask Lee, how old are you, Lee?
I am 82 now. We were in the middle of a snowstorm. I spent 3 hours a day, Sunday night, Monday, and Tuesday today to dig out. But I dug out. I do it slowly, an hour at a time. But I'm able to do it, and I'm still going strong, as you will, with treatment.
I guess some things that are skewing some of my looks too. I know prostate cancer, the field is expanding quickly. I've been really following the immunology treatments. There's Jim Allison, who had a documentary a few years ago. He's at the MD Anderson Cancer Center. And I know sometimes you can't wait for new advances to help you out where you are at today. But also some of the research, I guess, that I've done, that people that have been treated, sure, the cancer is blasted out of your body for 10 years, and then there's recurrence. Well, then, or is it worth the side effects to get to that point? And I guess that's kind of in the back of my mind as I'm looking at treatment options.
I mean, if this cancer is outside of the capsule, and with what you're saying, it's highly likely that it is. With a PSA of 48 and a 4+3 Gleason, yes, you're never going to have cure. And there's always going to be the strong likelihood of recurrence. And there's always going to be new things coming around the corner. That's the name of the game. And you've got to be willing to deal with them. I can tell you that the Jim Allison's immunology approach doesn't work just yet in prostate cancer. There are no positive results unless you happen to carry a certain couple of mutations, which is one of the reasons we've told you to get tested. But for probably 98% or 99%, immunology doesn't work just yet. We're working on it. There's all kinds of research, but it doesn't work. Dr. Russ, you wanted to say something.
Yes. Can you hear me?
Yes, sir.
Yes. I believe we are an advisory group. We're not in a convincing group, and I think we have somebody that's immutably stuck on no treatment. So why don't we get on to the other 39 people here that have issues where you can advise them? So,
sure. I'm okay with that too. I don't want to take up all your time.
But I can tell you why. Because many of us in this group, if not all of us, but many of us, maybe half of us, have seen the suffering that results from people who choose not to have treatment. And it hurts us. And as an organization, we want to just make sure you have free will. You can decide what you want to do. We don't want to see that sort of suffering. And it's not inconsequential suffering, Dr. Russ. And that, I think, and that's all we can do. We can only convey that. We can tell Ron that he could easily live out the expected 15 years that Dr. Paul, and maybe more, maybe get to 93 with all the different treatments that are out there. He's not going to get to that point scot-free. And the way his life has been in the past, he's not. But also, hopefully we can minimize that suffering for him. And I think that's why many of us do, Len and Dr. John and myself, and some of the other people who are in this group right now, you and Dr. Paul. That's why we do what we do.
Thank you. Yeah, no, I'm here just to listen and to actually, I want to learn from everybody else in this group.
Okay, Larry, I see you're recommending treatments for Ron already. I'm not sure he's at the stage where he's ready to listen to treatment options. First, I think he needs to be convinced that he wants treatment. So in the interest of moving on, Larry, I'm not going to call on you, okay?
You talking to me?
Yeah, Larry from Alaska.
No, I was just going to say, and I put this in a chat for Ron. Treatment you can put off progression without actually going into a treatment, and it'll preserve your quality of life and length of life, mostly, until you die of something else. That's it.
All right, we must move on, guys. Let's go now to Greg Bauman. And Greg, you are a bona fide newbie, right? Where you've never been to AnCan before?
First time.
First time. Okay, so tell me first, how old are you?
I'm 66.
66. And where are you living?
In the Seattle area,
Seattle.
Washington.
Okay, and do you know what your Gleason score is at this point?
Well, they took 12 cores out, and three of them were 4 + 5, so 9. And there was a 4 + 3 and a 3 + 4 and a 3 + 3.
All right, I think you said that you did have one Gleason 9.
No, I have 3 of them.
3 of them, okay. And have you had any treatment yet?
Yeah. So the biopsy was done in September of 24. So I've had, I'm on ADT. I have had 33 treatments of radiation. And presently I'm on Lupron and darolutamide.
Okay.
Been on other ones, but they've done stuff to my organs, so they've changed it. I did Abby before. And then I did another one. It messed up with my liver. So the darolutamide's been great. Everything's back to normal. I am in remission for about almost a year now.
Okay, and when you say remission, you're still on therapy.
PSA.
What?
My PSA is undetectable.
Detectable, okay. Well, we would say you're in remission with an undetectable PSA if you weren't on therapy. The fact that you are still on therapy, I'm not sure we characterize that as in remission, but
okay, what do you characterize that as?
I characterize it as you're under treatment that is working.
Okay.
Whether you're in remission or not, I guess I don't know. Rick, what do you think? How do you define remission?
Yeah, no, I would say you're in treatment. You're not in remission. The cancer has not remitted.
Yeah.
If we stop treating you right now, if you came off the Daro and you came off the Lupron, and your PSA didn't rise, you'd be in some type of remission. But we don't know that until you stop.
All right. I wasn't aware of that, and I just, I know I'm not cured, but I didn't know about the word remission actually meant not being on any treatments.
How long did they recommend you stay on hormonal therapy?
He said at least 2 years, but it could be forever. So kind of
Okay.
open-ended right now.
Right. And how often are you checking your PSA?
Every 3 months.
Okay. And was there any unusual pathology from your biopsy other than adenocarcinoma, things like intraductal or cribriform pathology?
Yeah, it's intraductal prostatic carcinoma.
Okay.
On all the nines.
Okay. Was there any evidence? Did you have a PSMA scan? I'm sure you did.
Yeah. Mm-hmm.
And was there any evidence outside of the prostate?
Oh yeah. Yeah, I had like 3 spots in my chest at lymph nodes, and 1 outside the prostate around my groin area.
Okay, so they were all lymphatic. There was nothing seen in the bone or in the soft tissue other than the lymph nodes.
Correct.
And altogether there were 4 of those, correct?
I am not sure of the exact number. I think it was 4.
Okay, that's good enough. No, that's fine. And you had only what did they radiate? Did they radiate the prostate and the pelvic bed across the pelvic girdle, or what did they radiate?
Yeah, so they did my chest first.
Yes.
And I think it was 20 sessions there. And then every day, and then they did my prostate area next. So they did it all at once, the prostate and the part that was outside the prostate.
How many did they do to the prostate?
That was, I think, 3 weeks.
Okay.
And then I had my breast buds done because they had me on a estrogen patch as well.
Okay. And are you still on the estrogen patch?
Yeah.
Okay. So you had 30. Would you say you only had 33 in total?
I think it was 33 is what I counted. So maybe what I told you might have been off a little bit, but it was 33 that I counted.
Mm-hmm.
And only 3 of them were for my for the estrogen patch.
Where were you treated?
Fred Hutch in Seattle.
Oh, you were. And
so the radiation was done at UW Med Center.
Who was your radiation doc?
Dr. Takasawi. She's a kind of very young Asian lady.
Yeah, I don't know her. We don't know. And who was the urologist that you saw?
I only saw him 1 time.
Okay.
And I don't remember.
Don't worry. Do you have a genitourinary medical oncologist on your team? And who's that?
Yeah, Dr. Radishuri.
Yeah, I know of him. I don't know him.
Yeah.
We know Dr. Cheng, and we know Dr. Schweitzer, and we know Dr. Yu.
Well, he's very young too. He looks like he's, in his 30s.
Yeah. No, I've heard his name, but he's not one of the docs that we have a pretty good relationship with a bunch of the senior docs at Hutch, but we don't know any of them. Okay, Len, sorry, back to you. I just wanted to fill in a couple.
So just a few questions left here, Greg. Have you had any genetic testing?
Yeah, I did. And there's no mutations or anything.
No germline mutations, no somatic mutations?
Nope, nothing.
Okay. and you've been briefed on diet and exercise, the importance of those two things.
Yeah, so I initially went kind of all plant-based, but I just couldn't handle that. But I eat healthy. I'll eat my proteins, no red meat, but and I try to get all the stuff they went through, the, eat certain nuts and soy and, whatever. So I'm eating a healthy diet. I exercise every day, lifting weights as well as cardio.
Good, very good.
I gave up alcohol as soon as I was diagnosed. I had kind of
Very
an
good.
unhealthy lifestyle before. So I tended to drink a little bit and I smoked meats, and that was one of my hobbies is, going outside and cooking, smoking meats, and I don't do that anymore. Sold all that equipment. So changed quite a bit.
Okay, well, good. You're willing to change. And any questions you had for the group?
No, I mean, the reason I want to listen is trying to figure out, well, there's a lot of uncertainty. So nobody has given me any information on, other than me reading statistics, which scares the hell out of me.
Yeah.
How long I'm going to be on here? What do I expect? Okay, as things progress, where am I going to be at?
Yeah, unfortunately, nobody can tell you that, Greg. That's a
Well,
complete unknown.
Even with the high Gleason scores.
Well, all we could say about that is, generally speaking, it's not curable, which you probably already know, but it certainly is treatable. As you can see, you're being well treated, and your PSA is currently undetected. So, with your diet, your exercise, continuing on the medication, you seem to be doing all the right things. Just continue doing that, and hopefully you'll be one of those who lives another 10, 15 years or more. But we can't promise. Yes.
Len, share with Greg what your Gleason score was and what year you were diagnosed and what you've been doing since.
Yeah, sure. So I was diagnosed in 2014, Gleason 9. I had lymph node involvement, pelvic lymph node, and bilateral seminal vesicles. 6 of 6 cores positive with 95% cancer. And in 2014, they didn't have PSMA PET, so I probably had at least micrometastases in the bone. But at the time, those scans were not revealing anything in the bones. But 5 years later, 2019, they did detect bone metastases when I was in a clinical trial for PSMA PET. So I've been living now 6 or 7 years with bone metastases, and I've been on frequent drug holidays. I have good quality of life. So, hopefully you'll do as well or even better.
And you've been on ADT the whole time?
Same drugs that you were on, Lupron, darolutamide. I was on Xgeva as well, which I think possibly you should talk to your doctor about being on Xgeva if you're not already. Oh, well, you said you don't have bone mets, right?
No.
Oh, okay.
Have you had a bone scan? Have they looked at your bone density?
Yeah, I have osteopenia.
Okay. So I would definitely be talking to your, what's his name? Kadashuri, about whether you should be on PrCa because you're on extended, if you already have osteopenia and you're on extended ADT, it's definitely a discussion you should be having with your GU med onc as to whether you should be getting it or not.
Okay, and I know they had me on have me on like just some vitamins, some D vitamins. But should I be taking the
Yes.
D with the K2?
Well, what you should be doing, because we're not going to tell you what to do, what you should be doing is asking your doc whether D and calcium, etc., is enough, whether with osteopenia and extended hormone deprivation, whether you should be on a bone modifying agent, either Exgeva, Prolia, Zometa, something like that.
Okay. Are there side effects to that medication as well?
Yes.
I personally did not have
Go
any
ahead.
side effects to Exgeva.
Okay.
I don't know that some people do get bone pain, I think, right? But it's kind of transitory.
Right. So Lee Balin, you have your hand up, and
Yeah, I had a couple of questions, Greg. You mentioned you were on estrogen patches. Did the docs tell you the specific purpose for that? And I'm curious about what dose you might be on.
Yeah, so I had, really bad hot flashes. So throughout the day, all evening, totally sweaty, couldn't sleep. It was pretty brutal. And this was before darolutamide. So the darolutamide wasn't approved at that time, I think until March, to take it with just Lupron. I think you had to be on chemo. So when they put me on darolutamide, that was the same time I got the patch. So I'm not really sure what did it, but it basically took care of all my hot flashes. I mean, I might get one or two in the evenings, very mild. So it cured my problem. And, the patch, the only thing I had to have my breast buds radiated so I wouldn't grow breasts being on the patch.
What was the dose of your patch?
I think it's 0.5. What's the minimum? 0.25?
0.2, yeah, 0.25. That's
So they started me
that's a
there,
fairly
and then
strong
they
one,
upped
but
it.
yes, that
from
sounds
there,
about
so
right.
5.
Right, thanks.
Dr. Jack, go ahead.
Yeah, as you were talking about getting rid of your hot flashes on estrogen patches, did you ever draw blood estradiol? I'm very curious what it was that gave you such relief and how high your estrogen level in the blood got.
I don't believe they've tested that. I mean, I get all kinds of blood work done. In my blood work, other than my white and red counts tend to be a little low, but everything else is perfectly normal.
Maybe they never tested for it. I'm very curious what level you have to get at to get that kind of relief with estradiol, how high it has to go. But if anybody has that, maybe Dr. Paul, you have a clue what that level has to be to get that kind of relief that Greg is experiencing.
Well, they started me at 0.25, and it was very good, but it wasn't.
No, I'm not asking you the level.
How
I'm
many
asking the blood
times?
level.
Yeah, I don't think I had that done yet.
Okay.
All right, let's go to Steve and then Dr. Paul. Go ahead, Steve.
Thank you. Hey, on the estrogen, are they calling that estrogen add back, or is the dose higher than that?
I don't know what that is.
Okay.
Yeah, I'm going to say it's add back or add on, and it's given to relieve the symptoms that you were having, and effectively has done that. In answer to Dr. Jack, usually it's, I'll say, a range of 80 to 100 picograms per ml of serum estradiol level that'll ease the hot flashes, but it's variable from one person to another. And also that, while not quite enough to be a bone protective agent, it usually requires more than that, but it's certainly helpful in easing the osteopenia, osteoporosis cycle, because estrogen is a bone building agent. So hopefully your DEXA scan in the future will be show improvement.
Yeah, they did mention that.
And you were given that because of your symptoms retroactively. It wasn't a proactive, we'll do this to prevent. It was given to you because your symptoms were significant enough that they felt that this would be helpful. Is that my understanding correct?
Yeah. Mhm.
Yes. Thank you.
Okay, thank you, Dr. Paul. And we have another new member with us, Raymond Canova.
Okay, Len, before we move on, do we have your email address, Greg?
I believe so. Do you fill that out when I registered for the group?
Well, you don't have to register for the group. Did you receive a reminder from us for this group?
No.
You did not. So then you
Nope.
didn't. So what you probably didn't. So what I would suggest, if you give us your email address, we don't require the email for you to enter the group. We will sign you up for a newsletter reminder that comes out before every meeting. So that's 4 times a month. You can put it in the chat window. That's probably the best way to do it. And I know Jim Marshall would like to know, are you a veteran?
No, I'm not.
Okay. So I will put in a second something in the email address, or you can go on our website, or you can just send it to me at the bottom, or send it for everybody. And then some of the other Seattle people might even reach out to you. It's quite a family here, and people tend to help each other. Steve L., who spoke to you before, he lives in your area, and there are other people. So.
Okay, very good. So I'm not real familiar with this format, so I can do it at the top right. I can add it in there.
No, what you'll do.
The best way.
The best way is open the chat window. Oh, you're on a phone, aren't you?
I'm on my phone right now.
Yeah, I'm not very good helping people when they're on their phone, but I don't know where the chat is. Well, how does he do it? Somebody who's on a phone, who uses their phone, can you just tell Greg how to give us his email address? I guess not. All right.
I can figure it out. I'll figure it out.
Oh, we forgot. I don't think we asked Greg how he heard of AnCan, did we?
No.
How did you hear about us?
Oh, I went to a group at Providence Hospital my first time last week, and there was a gentleman. I know his first name was Brian, and he was talking about this group. So,
okay.
Yeah.
Okay. So if you go, if you can figure out how to get to the chat window, it's the 2 little squares next to the number 40 in the top right.
Oh, okay. Yep.
And there are 2 little squares. If you press that, you can enter your email address in there. And if not, go to our website and just sign up on the website, or you can send me an email, rd@ancan.org.
And I have a suggestion. And since I have an IT background, we could do it really low tech. You could just tell him verbally what it is too.
I don't mind doing that. That's fine.
Okay, well, if you don't mind, Ron, the reason we don't say it is because some people don't want to disclose it. But
okay.
If you want to give it to me, I can take it.
Okay. You ready?
Yes, I'm ready.
It's S as in Sylvia, G as in Greg, my last name, BAUMAN, at msn.com.
SG Bowman with 1 M, right?
Correct.
At msn.com. We got you. You'll be hearing from us, and we hope we'll be hearing from you.
Perfect. Thank you.
All right. Thank you, Greg. And we will go to Raymond Canova Canova?
Canova, that's right.
Canova, okay.
Yep.
Just wave your hand so I can see where you are.
I'm right above you.
Well, there's nobody above me on my screen, but.
Oh, okay.
Oh, I see you now. Okay, gotcha. Okay, thanks, Raymond. Okay, so how did you hear about AnCan, Raymond?
I don't think I might have just been searching for support groups initially, and and I saw your name come up. I've gotten then I've gotten some mail from you guys, and tuned in. It looked like a bunch of nice people around here talking about a serious subject.
Yep.
Easy to fool people.
And how old are you, Raymond?
I'm 83.
All right. Nice head of hair for 83. And where do you live?
Yeah, especially after going through chemo. Yeah.
Wow.
I live in Hills Head, South Carolina.
South Carolina. Okay. And when were you diagnosed?
I was diagnosed in 2019, end of 2019, 2020. But actually, I pretty sure I had it 5 years earlier when they, a doctor I went to for I had some golf injuries, put on this report that I need to check my PSA out. And because he saw something, and he had a Tesla 3 magnet, and my urologist didn't want to mess with it because he didn't believe in MRIs. This wasn't an MRI nuke test. And I kind of insisted that he give me do a biopsy on me. And it came back with an 18-point stick with no, he saw it was negative from what he told me. And 5 years later, it comes back with an 8 Gleason. And I had 2 spots on my ribs. Went through 44.
What was your PSA at that point?
Actually, my PSA never really got too high. It stayed pretty much around 4. The only time it really went up is when he did the biopsy, and then it went down from there. It's well, later on I'll get to that, but it's anyway. I went on 44 radiation. PSA went down to 0. And that lasted for about 12 months, and the PSA started going up. Then I took the old normal route, went from there to Zytiga, Lupron, was on that for about 1.5 years. And then my doctor decided to take me off of everything, test it out. And unfortunately, after taking it off, about 5 months later, the Lupron had worn off. My PSA started creeping up. And the dumping time was quite severe. And
what year are we in now? When
we're in 2024, 23.
2023. So this is after 44 sessions of radiation therapy. Was that the
this was about 1.5 years. Pardon?
Was that the prostate and your whole pelvic region? The radiation?
Yeah, right.
Okay. And you mentioned something about a spot on your rib, I think?
I had two lesions, one on my 10th rib and one on my 7th.
Okay. Did they spot radiate that, or was that just taken care of?
They did about a year. Yeah, they did. Eventually, after about 1 year later, they took them off.
Okay, and that was successful?
Yeah.
So what medication are you on right now?
Right now, I'm on Lupron and darolutamide.
Okay. And how are you managing with side effects of that combo?
Well, they make me feel pretty tired. It's but I've been on Bob Newton's, I don't know if anybody knows too much about Bob Newton. He's got this exercise program, came out of, that I've been kind of trying to follow. He's big on weights and that kind of thing.
Good.
And
good.
if I do them, it works. I feel better. But if I take a vacation, go away for a week, it's like starting all over again when you come back.
Yeah.
Really
Ray,
gotta
did
stay
you say that you were on chemo?
Yeah.
And when was that? When was the chemo?
I did that. I did the chemo in 24. I was getting tired of the oncologist I was going to was but for one, he didn't read the scans. He had a radiologist reading the scans, and I wasn't too really comfortable with that because he had just gotten his machine, and I ended up went to MD Anderson, had a horrible experience, and then I also got I went to Mayo, and I'm seeing Dr. Kwon.
Is that
and
who you're seeing?
He looked at all that. Pardon?
Is Dr. Dr. Kwon is running your treatment now, and at Mayo you had a bad experience. Who was the doctor you saw at Mayo?
Oh man, I wish I remember.
Sorry, not at Mayo, at MD Anderson. MD
Anderson. See, I forgot his name. I'm trying to forget that whole experience. But I they told me to come to Mayo. Came with my wife. They assured me they had all my information. I just had a PSMA that was sort of questionable. I mean, it seemed kind of everything looks okay, but we got a lot of stuff floating around, and we're not really sure. And so I was hoping that doctor would read it, but he says I don't have your study here. And so he says, don't send it to me at Mayo, or don't send it to me at MD Anderson. Please send it to my home. So I did, and that's the last I heard from him. He never read it, and I tried to get a hold of MD Anderson a number of times and never could get any contact.
Okay. Well, I mean, unfortunately, we can't really get into that.
2 months later, I went to Mayo. I was in Mayo 2 months.
And who put you on the chemo? Was that Kwon?
That's Dr. Kwon. Yeah.
And did he put you on the chemo in Hilton Head? Correct.
Well, I was living in Hilton Head, but I did the chemo in Mayo. I go up to see. I'm up there every 3 months. He said the doubling time. He was concerned about the doubling time, and I was too.
Hold on a second. You said you went there every 3 months. So what was
Pardon?
Well, they usually give chemo on a 3-week cycle.
Oh no! I had my chemo in Minneapolis. I had a full course, 18 weeks.
You had 18 weeks on a 3-week cycle in Minneapolis.
Right.
Okay.
Yeah. And it's a tough go. But a year and a half later, my hair grew back. Everything seemed to, I had a lot of pain. First 3 or 4 cycles is not a fun thing. And the last 2 are really kind of harsh. But you kind of live through it. And no after effects of it. And my PSA has been pretty much undetectable since then. No further lesions. And I've been hearing what you say about that institution. I find at Mayo, I get a scan every 3 months. He alternates the choline with the PSMA. And I don't know why I get the choline. It's a metabolic.
We know what it is. Yeah, we know what it is, right?
Yeah. And until PSMA, there wasn't another PET scan. So I don't know. It's I guess that's some kind of I don't see anything wrong with it, but I just I feel comfortable getting a scan every 3 months. I get my blood tested every 3 months, and so far things have been going pretty good.
And what about genetic testing, Ray?
I haven't had any genetic testing. He said it wouldn't change my course of treatment right now. But he's going to do that next time I see him.
Yeah, but he doesn't know that. He doesn't know it wouldn't change your course of treatment until he sees, God forbid, well, he doesn't know that. But anyway, I mean, the guidelines are that with a gent like you, you should have had genetic testing 4 or 5 years ago. Those are the guidelines. He doesn't have to follow them. What can we do for you? How can we help you, Ray?
Well, I'm just curious to see, listen to everybody in here, and hopefully I can bring something to you guys, and maybe you can help me out in my journey. I'm looking to I'd like to get weaned off of treatment also, but just when I stop taking Lupron and my darolutamide, when will that be? The only thing I'm really concerned about is, I'm 83 years old. I don't think anybody should be scared of chemotherapy at any age, because it wasn't that big a thing to me. And I think that's what Dr. Kwon stresses, that it's not the worst thing. And it certainly wasn't for me.
No, what was your PSA before and then after chemo?
Before it was undetectable, because I was on Lupron, and I was on darolutamide 3 months before I started chemo.
Huh. Okay.
And what does Dr. Kwon say about giving you a holiday?
Well, we're going to discuss that next time I see him. He did cut my darolutamide to 300. I take 1 tablet twice a day now.
Okay. So the only thing we'll say, because we always do when Dr. Kwon comes up, is that he treats in his own fashion. It works very well for some people, but for some people it doesn't work well at all. If you like him, stick with him, but he's not a genitourinary medical oncologist. And we feel quite strongly that that's who should be treating advanced prostate cancer.
Well, he's been doing this a long time. I bet he's read more scans than any other doctor in this country. I can't imagine, because he was doing PET scan. He had introduced PET back in 2012.
I wouldn't bet the house on it. Wouldn't bet the house on it, Ray. But we accept the fact that he's very experienced. It doesn't take away from the fact that he's not trained in internal medicine, and to be treating advanced prostate cancer, you should be trained in internal medicine. Dr. Shellhammer is also very well trained. Dr. Shellhammer knows a lot about advanced prostate cancer, but Dr. Shellhammer would not be my choice of doctor if I had advanced prostate cancer. So all we're saying is, as long as you realize he's not trained to treat you, although he has the experience, that's all we're saying.
Oh, yeah. I hate to make this. I know you had a fellow here a couple of weeks ago. I think it was the 5th of February. I think it was a farmer. He was going to Dr. Kwon. And I think he started going to him in 23. I think he had about 18 bone lesions at the time. And on February 5th, he's talking to you about coming off his Lupron. And I think he told you that he said, I think he told you 6 months ago, I had a PSMA. 3 months ago, I had a choline exam. And when he said choline, everything shut off. Dr. Kwon, you're still going to get the PSMA 2 times a year. And I don't know how many people get a PSMA twice a year. So he stays on it. It's not like choline is just an additional thing he's got. Nobody else has choline. Very few people have choline.
Yeah, because it's useless and people don't use it anymore. That's the reason why. But Dr. Kwon loves his choline, and he uses it. And it helps him. If it helps you, it's fine.
He agrees. I agree. It's just
Ray, we've got too many people. We're not going to
Okay,
argue.
I understand that, but there are places for it.
As
There
I
are
said
places.
to you, if you are happy with Dr. Kwon, and that's all I've said, we just want you to know he's not a GU medonc, but if you're happy with him, that's fine. If you're happy with the choline, that's fine.
No.
He wants the choline. God bless him. Let him get a choline.
Okay. Parathyroid. Look at your renals. You're going to get better deal with choline because your renals will light up with under PSMA.
Schwartz, do you have a comment for us?
I'm sorry, huh?
No, I'm asking Bob Schwartz. He's got his hand up. He has a comment.
Question. Did I hear you correctly when you stated that your PSA was undetectable before you started your chemo?
No. Oh, no. It was up about 12, 14. It was rising. Okay. It was rising quite. Well, no, I take that back. But it given me the darolutamide about 3 months before I started my chemo.
Yeah.
So
right. So what was your reading?
Before it was about I think it got about 22.
Okay, I thought you said it was 0, and that's why I was confused on it. Thank you for clearing that up.
It was.
Yeah, that's what I heard too.
It was 0. It was 0 when I went on chemo. Yeah, when I started the chemo. But
that's what I'm saying. That's what I'm saying, right? He put you on chemo with the 0 PSA.
No. Yeah,
that's what you said.
I'm sorry. Right. You're right.
What I'm asking is, why would you be on chemo if you have a 0 PSA? I don't understand the correlation.
Because he was taking he was being aggressive with it, and I think that's one of the they say about Dr. Kwon, he's too aggressive, But it looks like the trend right now is for triplet therapy. I think that's the fastest growing therapy right now, and I don't know. That's what he believes in.
Raymond, here's the deal with chemo. Chemo kills rapidly dividing cells. It doesn't do anything if the cells aren't rapidly dividing. And in your case, with a 0 PSA, that's why Bob is asking these questions. It doesn't really make a lot of sense. But I guess we'll have to ask Dr. Kwon why he did that.
Yeah. And just for the record, triplet is not necessarily the fastest growing. Triplet is appropriate if you have a lot of metastasis, and then it is used. For men who don't have heavy metastasis, there's really no reason to use it, but some doctors like to use it, and you're not the first person we've seen. But like we say, Dr. Kwon treats in his own fashion. He's doing a great job with you, and you're happy with him.
Yeah, well, just don't be afraid of the chemo. That's my suggestion. It ain't that bad.
Okay, thank you for that.
It's my first time. I really don't mean to cause, but I did hear Mr. Opp a couple of weeks ago, and he brought up the fact that Dr. Kwon does use PSMA. He doesn't just use choline on every patient.
We're aware, right? We're well aware, and we've been working with David Opp for years, and we've always said the same thing. But certain docs like to treat in a certain way, and they want certain tests. I mean, it's like Peter Carroll. Peter Carroll at UCSF still likes Dr. Shinohara to do a Doppler scan. Nobody uses Doppler scans. Dr. Carroll likes a Doppler scan. It helps him. That's how, and Doppler scans are not used anymore. So yes, there are certain tests that are used, and he uses a choline. The fact that most people think that it doesn't have a lot of use, let him use it. Our concern is some of his treatment methods, and again, they work for some people, but they don't work for others. And we've seen him very, very slow on the uptake in treating people whose disease is getting away from them. So, that's how it is. But that you've listened to the recordings, what we think.
Yep. Yep.
Hey,
He's
Rick,
good help.
do you want to go to the next new member or?
Yeah. Thanks for listening, guys. I don't mean to be a first day here, but I did hear some things a couple of weeks ago that I thought were just not true. He doesn't just have one machine there he's working with.
Well, we know that. We say that. We acknowledge that.
Okay.
We acknowledge he has a PSMA, but he's only started using a PSMA in the last 18 months or less.
Oh no.
Okay. Let's move on because let's move on. Let's move on.
Do you want to take another newbie or until next week?
Well, I think we've got who was the next?
Carl. Someone named Carl.
Carl, do you mind if we take you next week? Are you there, Carl?
Yeah, I'm here. Can you hear me?
Yeah, we can hear you.
Can.
Okay, yeah, I certainly don't want to follow any of that up. So
okay,
look, try not to be too controversial. I listened to your 2 previous meetings, and I think I can next week I can give you most of the information that you guys ask. I can answer those questions. Okay. I probably have 2 questions. If at the end you have time, I would like to ask.
Right. So here's what we'll do. I will commit to stay long enough to do an intake with you at the end, and we'll answer your questions. And if
that would be great.
Drop off before then, we'll take you as a priority next week. How about that?
I'm not going to drop off because.
Okay, then I'll do an intake with you with anybody who wants to stick around at the end of the session.
All right, thank you so much.
Thank you, Carl. And so let's go with Paul Wynn. You wanted to ask us about radiation proctitis, I believe?
Yes, thank you. So quick history, I was done with a full 28-day treatment of external radiation January. So during that treatment, the second weekend, I started getting a little bit of rectal bleeding. Doctor gave me a suppository. It went away quickly. And then going forward, finished the radiation treatment. And I think in middle of the summer, I had another bout, real mild. I did the suppository again, and it went away in a couple of days. Now, going forward to October, late October, I believe, I started bleeding again. This time, it was persistent. Not severe, mild. It's really obviously after I passed stool. I would see some on the stool itself and in the tissue. And the worst case is I see, they start leaking out onto the toilet. So that scared me a little bit, but still, it's really after I poop majority of the time. Okay. All right. So I went to my GI doctor. The first 2 times, there was the suppository was prescribed by a radiation oncologist. I went to my GI doctor. Now note that I do have a history of hemorrhoids in the past. Anyway, so the GI doctor prescribed Sucralfate enema twice a day. So that's obviously it's self-administer, do it twice a day. The experience is not bad. It's just you just got to get in the routine. After you do so long, you're going to get to the right way to how to insert comfortably and all that. Anyway, so it's slowly improving. Hopefully and pray that it remained that way. And he's got me on this treatment for 2 months already, and going to continue for 2 more months. Now he said I can wind down to just once a day if I feel comfortable with it. But I think I'll go another week to keep on doing it to see, make sure it's long-term wise it's going to be okay. So basically, it's mild. It's not like alarming, gushing out thing. It's just a scary fact. I'm seeing that. Now, the last time I talked to him he thinks I'm he doesn't think it's going to get worse. He thinks I'm getting better slowly. And the interesting thing he said was during his closing remarks, I wish you don't see color. I said, what? What are you talking about? Because he's saying you seen blood and you freak out, and I said yes, I do freak out, and he said you're overthinking this. So basically, what he's saying is just accept it for now, and just hope it doesn't get worse, and it's just kind of thing. It's a lifestyle inconvenience, really, right? So anyways, I just wanted to share that. Now I know Rick did mention that I believe you, Len, that had maybe another gentleman that had some history of this after radiation. So the question is, if you can share that and what's any suggestion you have or the whatever treatment you had previously.
Yeah, sure.
One more thing to add. Sorry. So this is what the typical for the mild case initial treatment is the superfoot enema. I know there's some research. So if it gets worse, it'll be one or two things, ACP or APC, I forgot which one. It's kind of a laser kind of thing treatment. And then the other option will be a barometric chamber. You go in there and you sit for, I don't know, hour or so to breathe in oxygen. So obviously you don't want to go to the next step. So anyway, sorry to interrupt, but yeah, if you have any history to share or you have any suggestions going forward.
Yes, I do. I had a late stage proctitis, radiation proctitis. It didn't affect me until almost 2 years after I had radiation, and I had extremely high dose of radiation to the prostate and the whole pelvic region. So when I started bleeding, I was told by some people, oh, don't worry about it, it'll go away. So after about a year waiting for it to go away, it never did. So I underwent the argon plasma treatment, which I think is what you were referring to as laser treatment. It's not really laser, but it's like having a colonoscopy. Okay. And they were successful, I would say, in mitigating the problem about 95%. They were unable to use the argon plasma on the rectum, not the rectum, the anus, because they said, well, he said, you wouldn't like me if I did that. And then my oncologist said, yeah, because if he did do that, you would have had chronic diarrhea. So hopefully, if you get the argon therapy, argon plasma therapy, whoever does it will know that. But it's been years since I had that, about 4 or 5 years now, and it's been not a problem at all. I'll see occasional blood in the toilet from the anus. No big deal. I just, wipe and get on with my life. Now, the other option you mentioned, by the way, I don't know if I mentioned this, the argon plasma is a type of cauterization. It's basically what they're doing, they're cauterizing the blood vessels. The barometric chamber is not as effective as the argon plasma. And there's and it's many sessions, as I've heard, I think over 30. Correct. And it's time consuming. And we had one member of our group who developed cataracts right after that, and that's a known side effect. So, I think generally agreed that argon plasma is a better option in the barometric chamber. I'm glad the sucralfate is working for you. I never tried that. It was never recommended. So yeah, that's about it.
Yeah. So basically there's two categories, acute and chronic. So when my GI doctor did the scope, he did see indication of both, more of the acute than the chronic. And obviously, I think if I get it right, the acute can become chronic. But anyway, so basically, the routine, and obviously you gotta get my water in. I'm bad with and taking water, and then make sure I get enough fiber into. And then the other thing I do religiously is Miralax, about 3/4 capsule every night, mix it with some prune juice, and that stuff works. I will go. I mean, the only thing my doctor did say that don't overdo it because actually the whole idea is to poop less frequency because obviously the more you poop, the more damage, you're still passing all the tender tissue there. So minimize the poop. It's kind of like a catch-22. So I'm still trying to get that science down where he said 1 to 2 poop a day maximum. So I'm trying to get to that phase, and then obviously, and then go from there. But yeah, the APC, yeah, he did mention, my doctor did mention. That's why he hesitate. I mean, that's the worst case thing. Because yeah, he said some effect. I think he probably it's a diarrhea thing. It's got permanent damage to some tissue down there.
I'm going to jump in because we've really got to get, there are two
Okay,
hands
go
up.
ahead.
We've really got to keep moving along. If there's anything you particularly want to ask in addition, Paul, gather it up, wait until the end of the question and we'll finish up with you. Len, you want to take the questions?
Go ahead.
Yeah, sure. Gary Peters, go ahead.
Hi, Len. I was just going to ask, what kind of a doctor did your argon treatment?
Oh, you have to go to a gastroenterologist. It's basically like having a colonoscopy, Gary. There's no, as far as you're concerned, you're having a colonoscopy. The only difference is that while the scope is in there, instead of just looking around, they're cauterizing the blood vessels that are causing the bleeding from the radiation. Yeah. Okay.
Thank you.
Yeah, my GI doctor does say that he can do that, but like I say, he hesitates for now.
Yeah. Okay, Larry, go ahead.
Just one word: bidet.
Oh yes. Okay, so my brother told me that too. So basically, what I do is I have a handheld shower, and as soon as I do my mission number 2, I jump right in the shower and get the handheld shower, first low volume and mild temperature, and I'll just spray the back end thoroughly. Yeah, I think it's the same effect.
All right, Paul, is it okay if we move on? We've got a lot to get to here.
That's all. Yeah. Okay. I mean, further on, if you don't mind, Len, I'll either come back here. I'll reach out to you.
No, I don't mind.
I don't want to.
Yeah,
okay.
it's fine.
Thank you very much for the time.
You're welcome.
Thanks, Rick.
Let's go to Richard B. We have to go to you because we bypassed you last week. Go ahead, Richard.
Okay, thank you. Yeah, I had a conversation with Rick, and he suggested I bring this up in this group, so I'll try to make this efficient here. But I'm 79 years old, 17 months now post radiation treatment, went through SBRT. The PSA has not reached a nadir yet. Went from post radiation 587, then it went to 3.5, and then 2.4, and then bumped up a little bit to 2.8. But what just occurred was that I had a blood test for a whole separate issue, and it's come up showing that I am in stage 3B chronic kidney disease. My EFGR is 39. I had a sonogram of the bladder and of the kidney, and the combination of the two and the clinical reading here shows that the prostate is mildly enlarged at 37 cc's. The impression is I have bilateral cortical thinning and increased ethnogenicity. And with the mildly enlarged prostate, I have significant post-void residual urinary volume. So given all of this, my question to the group is, has anyone had any post-radiation side effects of this type. I mean, the creatinine level, if I'm pronouncing it correctly, is high. So the one I haven't had my follow-up with the nephrologist yet, but before the sonogram, his theory was perhaps the bladder, which is supposed to contract and expand, is not expanding. So he thinks that the urinary fluid is going back and staying in the kidney, and that's where the toxins are residing and giving all the high numbers. But if anyone had any issues that with post-radiation has led to this type of outcome.
To go to Dr. Paul first before we hear from anybody else. You want to comment on Richard's condition? Dr. Paul, are you still with us? I guess not. Okay. Well, let's see. Somebody's got a hand raised here. Dr. Russell, go ahead.
In lieu of Dr. Paul, because he's really would be key in this discussion. But I mean, you have to think about that. Was any of the words hydronephrosis, was that ever mentioned in that report?
No, sir.
No. All right. So anyway, yes. I mean, this is unusual. You can get obstructive uropathy from enlarged prostate, but I mean, I think the urologist needs to be involved in figuring out what's going on here, because but I've had reports of my glomerular filtration rate going less than 50, and then the next time it's close to 90. So, but a creatinine elevation to me is worrisome that your renal function is disturbed. So I think, definitely nephrologist and urologist needs to figure out what is the issue here. So.
Okay, so then based on what you said, I should go all the way back to the urologist that first detected everything and handed me off to the oncologist, and now I'm seeing a nephrologist. So you're suggesting I go all the way back?
Yeah, the nephrologist deals with intrinsic renal disease, and that would be unrelated to the irradiation.
No.
So I'm trying to think of is there an anatomical reason for your kidney dysfunction? And so I don't know what the imaging studies show, but it doesn't sound like it's hydronephrosis, which would be a cause for impairment of renal function. And there are issues, I mean, that would mean intervention to relieve the pressure, the back pressure on the kidneys. But so I would think it'd be a reasonable thing to have both involved to figure out what it is. But the radiation could not affect your kidneys. The creatinine,
okay.
Yeah. So the creatinine, what impairs renal function anatomically would be something that's obstructing the outflow of urine. So again, but Dr. Paul, I wish he were here. He could better elucidate this.
Yeah. Right.
So we have seen in the past, and I'm thinking about Rob Beniscus, who this room is named after. We've seen a few guys have to have stents placed in the urethra as a result of post-radiation from inflammation to the urethra that's caused a backup. Not in a while, but Len, you probably remember this, and that Rob had to go in every few months to get those stents replaced, and we've had other people who have had issues with the stents. And I thought the cause of that was in some way, shape, or form related to radiation damage. Dr. Ross, you have your hand up again.
Yeah, and again, I mean, anytime you get radiation anywhere in the body, it's an inflammatory reaction, and you can get some edema and swelling. So I guess even though the word hydronephrosis wasn't mentioned, if you have thinning of the caelogeal system, it suggests that there may be some obstruction. I mean, I think this is more of a anatomical problem related to the renal dysfunction than a medical issue.
Then the radiation?
Well, with the radiation, the radiation has affected, as Rick was saying, it affects the prostate, which again then can lead with the edema. It's sort of like we call BPH in old guys, where when the prostate obstructs the urine, and you can get hydronephrosis from that. So anyway, we need Dr. Paul, but I'd say that I would certainly want to talk to my urologist about what's going on.
Right.
Okay, I appreciate that feedback, and this is so recent that I've yet to have the follow-up appointment with a nephrologist to discuss the sonogram. So that's I'll probably get that scheduled. Talk to his office tomorrow and get it scheduled here real soon.
And then we had another guy, Glenn, Jim, in who's now in Martha's Vineyard, who was at Yale for a long time. You remember?
Oh, I was thinking of somebody else, another Jim, the guy
James.
who was a laser scientist.
No. I'm talking about James K. And he has a stent. He's had a stent put in. You know who I'm talking about?
No, I'm afraid not.
Okay. Yeah, you do know. I'll send you a message.
Okay.
Okay, I appreciate all the feedback, and I'll come back to the group when I have my appointment on the follow-up to the sonogram. Thank you.
Okay. Dr. Russ has one more question for you.
Well, as sad, I'm not a urologist, but based on what Rick's saying is that you've had people in the past that have had stents, and a stent is placed as a temporary process. So what were they doing? They were relieving the prostatic hypertrophy that was leading to the backflow. And if you have backflow, that sonogram suggests that there's involvement of both kidneys, and you get that only from something down distal, which is either bladder neck obstruction or a prostate obstructing flow.
Oh, okay.
All right. Thank you, Dr. Russ. And Richard, maybe come back next week, and hopefully Dr. Paul will be here and get his opinion.
Good deal. Thank you.
Yeah, Rick, I'm getting a pop-up message here. Someone is waiting unlocked to let people join. Do you know how to handle that?
Yeah, I don't know how we got locked, but
I got it. I unlocked it.
Okay, thank you, John. Okay.
And I want to make sure Richard does see a nephrologist as well as a urologist. I'm with Russ on that.
Okay, he's got thumbs up to you, John. All right, Dr. Jake, what have you got for us? Jack, I'm sorry.
Yeah. Okay, that's me, Jack, not Jake. Okay, I share every couple of months because I'm sort of the canary in the coal mine. I wish Dr. Paul was here because this is sort of an esoteric situation that nobody has really dealt with in this group. But who else can I share it with if not this group, my medical oncologist who I saw yesterday. So after 10 months on a drug-free holiday, my PSA fortunately is still undetectable. And I've taken Clomid, clomiphene, 12.5 milligrams every other day. Being conservative at my age, approaching 87, I didn't want to overdo it. And my testosterone, unfortunately, only moved from 25 to 26 in the 9 weeks that I've been on Clomid. And Dr. Belusic said I should increase the Clomid to 25 every other day, if not every day, which I started this morning. And what happened is the testosterone was not only low, but the sex hormone binding globulin was high, 97.1, not unexpected at the age of 86 and a half. So the free testosterone was most likely very low too, with the albumin being 4.2. The estimated free testosterone is extremely low, consistent with a hypogonadal state as a result of suppression over 2 years with ADT and my age and everything else. I thought taking Orgovix and starting with a 765 testosterone would give me a more robust bounce back, but it's not happening. I'm discouraged, but at the same time hopeful that maybe it'll take 3 months, which the literature says, for the Clomid to kick in for me. But it doesn't look very promising. But I'm going to stay with it for another 2 months and see what happens. My luteinizing hormone was 9.7, which is still high a bit, but lower than it was 13.2 2 months ago. FSH was 55, then it's down to 25.8. So my pituitary hypothalamic axis is trying to do some work, but my gonads are not very responsive. So the CBC parameters and all the other blood parameters are all popping up, getting relatively healthy, which I hope was a function of the testosterone going up. But whatever it is, it's certainly optimistic because I was very concerned, especially the absolute neutrophil count, which was 1.29 last time, and it's up to 1.83, better than 1.2. But I can't quite understand why it stays low, and we're speculating that maybe it is the SBRT on the L4 vertebrae and the ribs, because we were talking about how cancer seems to operate like a vampire. It goes in to get the healthiest bone marrow, and it really goes right for that like a magnet, and it then that could affect the bone marrow that is most enriched hematopoietically. So I also want to mention my DEXA scan, minus 1.8 and 1.9 in the hips. So I have osteopenia, a 2.8% chance of a fracture. Whether or not to treat or not to treat at this point, I'm going to wait a couple of more months, see what the testosterone does with the Clomid, and whether we're going to continue that. I'll probably go on prophylactically at my age. It probably would be wise to do the reclassed zoledronic acid and treat it as a osteopenia rather than a metastatic lesion, nothing showing up unless the scan shows something. Otherwise, then I'd reconsider, PrCa or Exgeva. But right now, the reclassed IV, I would prefer 5 milligrams once a year. My alkaline phosphatase is 139. He believes it's bone turnover rather than metastasis. And that's kind of a summary of where I am, but any feedback I'd appreciate. But I just thought I needed to talk about it because I don't know who else to talk about it with.
Well, I can tell you in my experience, Jack, that it takes a long time for the red blood cells and the hemoglobin and hematocrit to recover from radiation and hormone therapy. But mine's now at 13 and 39, or actually 40, I think the hematocrit was. But it took, I've been on drug holiday now for the last 14 months. And so it took that long for it to go from 12.1 to 13.1, the hemoglobin. So it takes time.
Yeah, I noticed that. My hematocrit and hemoglobin are responding. 14 hemoglobin, 42.6 hematocrit, and so it's that 1.83 absolute neutrophil count that kind of really is confusing to me. Why that be so selective about that?
Yeah. Any other comments?
Any other feedback?
Well, disappointing so far about the Clomid, but I suppose the dose being so low, we can't make any conclusions at all. You're going to go ahead with the increase, it sounds like.
Yeah,
So we
no,
look
I'm going to
forward to
increase it,
that.
give it 2 more months. And my estradiol went up to 26. That's the reason I was asking before about estradiol, because I still have, hot flashes. And my estradiol went up to 26, and certainly I still break out in sweats and everything. So I was wondering from Dr. Paul, he said it has to go to 80 to 100. And I asked about the estradiol. I said, well, do I have any aromatization going on here from the testosterone? He says he doubts it at that level. He said, but it's possible to some degree that could account for my estradiol. He said, but the Clomid in and of itself, an estrogen receptor modulator, is going to cause an increase in the amount of estradiol. So that's probably a cause for the elevation of my estradiol. I don't know if I'm imagining, I think I'm getting more breast tissue than I'm used to, and but no pain in the breasts. So we'll see what happens over the next 2 months. And if I have to go off the Clomid and recognize that, the old balls just didn't make it, and so that's life. And if I stay alive and my PSA remains down and I can, keep moving along, I have to be grateful.
Wise words, Jack.
What can I say?
Okay, how about we go to Tony Fig?
I'll wait until next week, Len, so check back then.
Okay. Then how about Gary Martin?
Yeah, quick update. My PSA has dropped 1.5 down to 0.08 with the triplet therapy, a couple of months past chemo. Did have a couple questions about immunotherapy. Rick mentioned we were not there yet, but I do have the genetic profile that does qualify me for the one of the checkpoint inhibitors, pembrolizumab. I'm not sure I can pronounce that, but was wondering anybody in the group had had immunotherapy using a checkpoint inhibitor, and who was the provider, what institution did they get their treatment?
So I'd say a couple of things to you, Gary. First of all, you're at 0.08. There's no real reason to jump in with the checkpoint inhibitor at this point in time. What is if I remember correctly, it was just your tumor mutation burden, your TMB, that was high. Is that right?
Yeah, 76, very high, which qualifies for that.
And is this something that Dr. Schmulowitz has mentioned to you, or have you discussed?
No. I'm just thinking ahead, and maybe want to get in at a provider who's knowledgeable about it.
Well,
if at some point.
Dr. Schmulowitz is the provider.
Okay.
I mean, that's who you would want to talk to.
Okay.
You don't have any mutations, is that correct?
Yeah, I do have several. TP53.
TP53, right. And your TMB was initially at 78, but then in 1125, I have a note that your TMB was down to 7. Is that right?
I believe it was around 4.5 with the.
Okay, so we got to stay honest. Otherwise, we're all going to get confused. If your TMB was 78, but after chemotherapy, it was down to 4 or 5.
Right.
Why are we talking about immunotherapy? We're not looking for treatments.
Okay.
And there's no point. And I sort of sometimes have to remind you guys, we can sit here and chase ourselves up our own ass to find treatments when we don't need them yet. Because the problem is, when you are ready for that treatment, then is when we have to find out, are you eligible? For you to go and talk to Dr. Schmulowitz right now about, am I eligible for pembrolizumab? He's going to say, well, No, you're not, because your TMB is too low, and you're going to say, well, it was 78, and he's going to say, yeah, but the triplet therapy worked, right? So let's not come into this group and say, what about this, what about that, what about the other, if we're not good candidates for it now when we need it, right? Because things change. This is why we say to you guys, you have to repeat your somatic testing.
Repeat it. Okay.
And you know, maybe your somatic test will come back and maybe it will show that you've got a BRCA mutation. This is why it drives me nuts when Dr. Kwon says it's not relevant. It is relevant because these things change all the time. And he doesn't know how it's going to change. You know, Ray Canova could go in there next time. He could have a TMB of 50.
Right.
And you know, and that would say, well, he should have got pembrolizumab a while back, but Dr. Kwon never checked him for it, so Dr. Kwon never knew. So what's important is that we're doing these tests consistently, and we're changing our game plan in response to the somatic results that we're getting. And in your case, we shouldn't even be talking about pembrolizumab because the last test that we did for you was great.
Right.
So I don't want to talk to you about immunotherapy right now, but if it's appropriate, we'll talk to you and we'll tell you the ups, we'll tell you the downs. Yes, we've had guys who have been on immunotherapy and they've responded in different ways, but we're not ready for that with you right now. Len, would you like to add anything to that?
No, but John's got his hand up.
Dr. John.
Yeah, Rick is right. Of course, we don't want to move toward an obnoxious treatment at a time when you're responding so well to triplet. But we also have to be careful to compare apples to apples. I think that Gary's tumor, which when you test the tissue itself comes up with a very high tumor burden, is a tumor that is not shedding nucleic acids or cells into the bloodstream very readily. And therefore, a liquid biopsy showing a 5% tumor burden cannot be compared with a solid biopsy showing a 78% tumor burden. So when you do get tested again, compare liquid to liquid and solid to solid so we don't misunderstand.
Okay, so they would redo the biopsy of the prostate at that point?
Well, the best thing to do is to get you have some metastasis. Well, you know that when you do a biopsy later on in the course of your disease, you can go back to the prostate, but if the reason for doing it is to see whether there's any new developments, progressions, mutations, and so trying to get the most recent example of a metastasis is probably better than going back to the original tumor. Okay. Or maybe another liquid biopsy could be done, and then you could, but you know, like I say, at least in the past, your tumor does not shed too much into the bloodstream, so liquid biopsy may not be as useful.
Correct.
Yeah, but John, a couple of things, and this is really, you're raising a really important issue, so I'm glad you came up with it. I mean, what I'm hearing you say is we can't be comparing tumor mutation burdens between liquid and solid samples.
That's what I think, yeah.
I've not heard that before. And what concerns me, if that is the case, is how that impacts how the pembrolizumab, the anti-PD-1 is going to work. Because could work, you know, if it's in your blood, it's right the way through your blood, and the T cells are working right the way through your blood. If it's only in a particular spot, then is the pembrolizumab going to just bear down on that particular spot? And I'm just concerned because that's not, like I say, I've never heard that you can't compare. And I've heard people, you know, I've seen doctors where your TMB is 8, 9, 10, and they'll say, oh yeah, that's high enough to use an anti-PD-1, an immunotherapy drug. So I'm just not sure on that. And yes, 78 is really high that we know, but you're saying, well, 78.
So I think that I think you're quite right. You see, when Gary's tumor burden appeared to go from 78 down to 4 or 5.
Yeah.
One person, like maybe Rick in this case, might conclude that you're responding to therapy, and another person, like me, might conclude that you really are 78, but you're just not shedding into the bloodstream. And
yeah, so
I wouldn't necessarily fight for my interpretation because I'm no expert in this.
Okay. Well, that's good to know. I was just thinking ahead to next steps. But
Well,
yeah.
First of all, I think let's see how you do. God willing, you're going to stay down at this low level, and then we're going to get you on a holiday and all the rest of the stuff. So we don't have to worry about what's the next treatment.
Okay.
At the same time, next time you meet, which I hope you will, you'll continue to see Dr. Schmulowitz. This is a discussion to have with Dr. Schmulowitz and say, well, did my TMB go down because I responded to the triplet therapy? Or did my TMB go down because one was a liquid sample and the other was a solid sample?
Oh, I would love to know that. If you ask that question, come back and tell us.
Okay. Yeah, I'll follow up with him. Thank you.
Okay, but I'm chastising you in a good way in that I don't want you guys to driving yourself nuts because you're always going to find something to worry about, and that's just not a good thing. And we don't need to. Yes, we need to look ahead, but not so soon after triplet when your PSA is low. Now's the time we should be thinking like we've got some guys here who are able to put it into the back of their mind and go out and enjoy the world like Lee Balin. I think he left, but go take a trip with the wife somewhere, or and don't sit at home thinking about what's my next treatment going to be.
Okay.
Because we're a support group after all. We want you to be better.
Right.
Not cured. We can't cure you, but we want you to think positively. We want you to feel good about yourself. And that's never going to happen if you're always saying, oh my God, I'm doing fantastic, but what's my next treatment going to be?
Yeah. Getting too far ahead. Okay. Thank you.
Julian, you're next.
Oh, just a quick update. My PSA was in the dirt, 0.014, and it's been like that for about almost 5.5 years. The only thing is my testosterone is gone down to the dirt too, so can't have it all. That's all.
Okay, and so you're on a drug holiday, but your testosterone hasn't recovered. Is that right?
That's correct. I've been on a drug holiday for about 5 years.
5 years, and what is your T level?
I hate to say it's about 10. It hasn't come back.
Yeah.
It started coming back, and then it just slowly started going down and down and down, and it has not recovered. It got
And
up
how
to
old
one.
are you?
Pardon?
How old are you?
I'm 73 right now. I'll be 74 in a couple of months.
And how long were you on hormone therapy?
For about 9 months.
That's it?
Yeah.
9 months, and
But it was a doublet, yeah.
That's surprising that your T levels didn't come back.
Oh. It has, I mean, I don't know why, but it's not there.
Yeah.
It's at 10 right now.
Yeah.
Like I said, you
Okay.
can't have it
Anybody
all.
have anything? Yeah. Anybody want to add anything? Jim, go ahead.
Julian, holy smoke, you have me beat. Anyway, I was on treatment for 5 years, and the holiday is now 3.5 years.
Yeah.
You're on 9 months, and you get 5 years. Ah, you
Yep.
lucky dog.
Yeah, well, I was very aggressive when they first, my PSA went up to 8.7, and then I let all hell break loose against this cancer.
Julian,
Okay,
what does Dr. E say?
I've not talked to Dr. E.
Well,
I don't know where she's at.
Well, she's
not at
available.
Houston Methodist. I don't know where she's at. I don't know how to get a hold of her.
Have you tried to send her an email? Because she has said, we've heard that she's continuing to see her existing Texas patients because she's in Texas a couple of days a week. So my suggestion to you is to try and reach out to her, and if you get rebuffed, let me know and we'll help you. But I think
what I did let her know that my testosterone was going down, and she never responded.
But if this has been going down, but you say it's been going down like this for 5 years.
No. It went up to 155 at one time.
So
it's been up, but it's it hit that top, and then now it's coming back down.
Okay, so when did it hit that top?
They hit the top in June 7th of 2023.
Okay, and it's been. And
I take that back. It went back up a year ago. In 2024 was up to 156.
Okay, so 156 in June of 24. Did you say?
No, December 24, December 27th of 2024. It was at 156.
So December of 24, it was 155, right? 154, right?
156.
156. And through the whole of last year, it's been going down month by month, correct?
Yes.
And what is it right now?
10.
And Dr. E only left at the end of December.
Correct.
So so all the time it was going down from 155 to 10, you didn't talk about it with her?
No, I told her. I sent her a text message, when she's at Houston Methodist, and she said, we won't worry about it right now.
And when was that?
Oh, that's been over a year now.
Okay, but I guess what I'm trying to point out is we can't resolve stuff like this. People come in here and they say, oh, this has happened. Yeah, but it's been happening for the last 12 months. We need to do something along the way. Whoever's got their phone on, can you please mute?
Larry from Alaska, mute yourself.
I've just muted him. So, yeah, I mean, a couple of things. The first is definitely reach out to her again.
Okay.
And she knows you. You have a good relationship.
Yeah.
Find out if she's still going to treat you whilst you're gone. I mean, did you not have that discussion with her before she left as to who's going to be treating me now?
Nope.
Okay. I mean, again, guys, you got to be your best advocates here. And not wait until the last moment and then something happens and then we don't know how we're going to get you treated. So find out what arrangements she's making, because I think she's making arrangements, and my understanding was she was still going to see her patients. Secondly, reach out to her and say, my testosterone is down to 10, because there could well be something else going on that has nothing to do with prostate cancer.
Correct.
We've got 3 doctors on the call. Any of you doctors have anything to say as to to what else could be causing this, Dr. Russell?
Yes. Again, I wish Dr. Paul was on here, but Jim Marshall had once said, well, he asked me, what's the cause of this? Well, usually it's pituitary overstimulation. So if you have something that's stopping that beta agonist, then you can have a failure of the pituitary. But Dr. Paul, last time we spoke about this, talked about atrophy of the testicular cells itself. And so, but again, I'm not an expert on this, but if after stopping it, that the total testosterone only went to 150, unfortunately, I think this is not a good prognostic sign. So anyway, we need somebody more like an endocrinologist or Dr. Paul to weigh in here. But so even though the initial cause is usually pituitary atrophy related to that stimulating cells, eventually there is some testicular atrophy related to the fact that they're underused. But I would say that that response 150 is pretty puny. So I hate to be the bearing of bad news, but you need somebody more expertise than me to weigh in on that.
Okay, thank you.
How are you feeling, Julian?
I feel good. I mean, I feel healthy. I am finally starting to lose weight. You know, I was at around 200 for the longest time. The last 3 months has gone down to 195. So I don't know if that has anything to do with it or not, but it's not easy taking off the weight.
Yep. Okay, let's move on to John Maxwell.
Good evening, everybody. Just want to give an update. I got a blood test done on like the 22nd, and my PSA and my testosterone are both undetectable. So I finished up my radiation treatment in May, and so I've been undetectable in 4 consecutive tests, and I'm meeting with Dr. Smolowitz next week. That's where I'm at.
Great news. Thank you for the update. Any questions for John? Okay. Alrighty. Joel, are you still with us?
Yes, I am. Dr. E has dropped me, so I need a new GU medical oncologist. And since I moved to Florida myself, I guess the question is for me tonight is who is the best GU medical oncologist in Florida? I'm willing to go any place.
Well, my opinion, you're not too far from Sarasota. Dr. Guancial,
Right.
Guancial.
Okay.
She is excellent. I've been with her for about, I don't know, 4 or 5 years now. Bob Schwartz has been with her. He likes her a lot. Anybody I know who's ever seen her thinks she's terrific. And, you know, she's a Harvard grad, residency at Mass General. You know, she was at Dana-Farber.
She did her fellowship there.
Did a fellowship, thank you. So, I mean, her credentials are great. Her bedside manner is terrific. Yeah, that would be my recommendation. The other one, I think, I know Rick likes that fella down in Miami, Belusic.
Yes.
So, I don't know, anybody else have any recommendations, Florida?
I'll tell you what, I got to endorse you on this one, Len, because I'll tell you what, Dr. Guancial is everything you said she was, and there's a lot of AnCaners that go there, so you can't go wrong there. And the guy in Miami is good too, from what I heard, but depends on how far you want to travel. Either way, you will not be in bad hands with either one of them.
Very good. Thank you.
I like Belusic, and I think Don
and Don Rogers goes with me. I think Jack, and I think we all like him. He's done very good by me so far.
Great.
I'm sorry, guys. I got kicked out and I just got back in. Who are we asking for, Len?
We're asking for Joel. He's looking for an oncologist, medical oncologist in Florida. We've recommended Guancho and Belusic.
Belusic, yeah. I think both of those are absolutely excellent. Guanciale is a lot closer to you, Joel. Well, I shouldn't say that. You're in the villages, right? So.
No, you're right. She is closer.
Sarasota's closer to Tampa, yeah.
Yeah.
Oh, that Joel. What's that Joel doing in the villages? Have you moved down there? Oh my gosh.
Yeah, I had to get away from the snow.
Are you there full time?
More or less, about 90%. I plan to probably be here about 90% of the time, yeah.
And Joel, I'll tell you, depending on which one you go to, you can't go wrong. There's like a group of us. We could form our own clubs at either one of those two doctors that were mentioned to you in Florida. That's how good they are.
Yeah.
Okay. Thank you.
Oh my gosh. So you're not gonna go to Portland on a back and forth 2 or 3 times a year?
She hasn't offered me that, and I'm taking the hint that see, I'm not a Texas resident, so I think she's probably dropping all her out of state people. But I don't know if there's any other out of state people who are Dr. E's patients. Let me know.
No, well, Julian, you heard what I said to Julian when I left. Sorry, Julian, and you feel free to send me an email, but yeah, we don't really know who. She really hasn't offered anybody else in Houston, because I did ask her specifically for somebody, and she didn't want to, but she did say she was going to keep seeing her patients. So we have to bug her. And Julian, if you can't get her, I will ping her and see what she says, but try and get to her. But yes, Belusic is cool, and Guanciale's great, and that's a little bit closer to you, I think, than Miami.
Yes, and matter of fact, she had ordered Dr. E had ordered a Tempest test for me, because she did that every 6 months anyway, and I never got it. I mean, her staff dropped the ball there, so it never went through. So and that type of thing has happened to me before also. So anyway, I might as well switch to Florida since there's 2 good GU med-oncs here. So thank you all for the info. I will definitely do that.
The other alternative is to leave your care up in DC and go see Channing Palla.
Yes, that's true. I could do that, but I found out that there's a VA hospital in the villages here, and the VA works very closely with the civilian side of the house in the villages. And and I'm getting a primary care doctor that has worked in both systems, a former military doctor. So I think I'm going to go that way. But yes, I could still go to DC, but they're in the business right now transferring my files. So they're going to be surprised to find out about 6 inches of paperwork. But anyway, that's the way it goes with the systems we have today. I was hoping they would have my chart down here, and they don't. All my other doctors I've had in the past, luckily, have been in my chart.
All right.
Okay, thank you, Joel, and good luck with either Belusic or Guancho. I think Guancho's much closer. You're probably better off going there.
All right.
Just out of convenience, yeah. And Saranan, if I'm pronouncing that right.
Yes, you did, Len.
Okay.
I am trying to plan things ahead. I was thinking about radiation therapy in MD Anderson. What are the positives and negatives about MD Anderson?
Sorry, but the question is,
I mean, you're in Rockford, Illinois, right?
That is correct. That is correct.
So why would you want to go down to MD Anderson when you're in Rockford, Illinois?
Well, that's what I was thinking before. Right now, I'm undecided. Maybe I'll go to Chicago, which is closer to me. And actually, it was my wife who heard something about MD Anderson and she contacted them. But I want to find out what are the positives and negatives before I make the trip over there. And since you have recommended Dr. Smolowitz, I would like to get everything done in Chicago itself.
So when's your appointment with Dr. Smolowitz?
It was last Friday.
And how did you get on with him?
It went well. He put me on Lupron.
Okay.
So
and just on Lupron. And did you like him? Did you get on with him?
Yeah. He came and explained everything, and I was there with him probably about 15 minutes or so. And I got my PSMA PET scan had no spots.
Okay, that's good.
And yeah, my PSA went from 0.19 to 0.3, and that it was the same day I did the PSMA scan. So, but it has no spots, and Dr. Smolowitz immediately put me on Lupron.
Okay, did he not put you on bicalutamide first?
No.
I'm disappointed. And so he gave you a Lupron shot right there and then?
Yeah, it's for the 3 month, 22.5 milligram or whatever. Right. Yeah.
I am disappointed that he put you straight onto an agonist and without the bicalutamide, especially with Dr. Smolowitz. But these guys, they do what they do. Look, here's the issue. You can come in and talk to us about other docs, but we've given you 2 doctors already.
Mm-hmm.
And if your wife wants you to go to MD Anderson, that's fine. But I'd rather not take up the group time to talk about the pros and cons of MD Anderson when we can send you to Dr. Antanarakis in Minneapolis. We can send you to Dr. Smolowitz in Chicago, and then we have some other choices in the area.
Okay.
To me, it's not a good use of our time. Our recommendation is go to one of those 2 places. Yes, we know the doctors at MD Anderson. We know them fairly well. Jim Ward isn't on here at this point. He's been at MD Anderson for a long time. But again, we got to focus on how we can really help you. And we think we can really help you by making sure your care is taken care of a lot closer to home.
Okay. That makes sense.
You know, I mean, MD Anderson, you're going to have to drive to Chicago. You're going to have to get in an airplane. You're going to have to go down and spend a day or 2 days down there and then come back. I mean, the logistical cost is significant. We'd like to take 10% of what you're not going to spend here at AnCan for ourselves, believe me, to put in our coffers. I mean, I wish people were as generous with AnCan as they are willing to travel all around the country for some of these doctors. And you don't need to. So why have a discussion about MD Anderson? If you lived where Joel lives, in the villages, yeah, of course we talk to you about MD Anderson. But we're not going to talk to you about about Dr. Belusic, who's a great doc, because you're so far away.
Yeah, that was before you recommended Dr. Smolowitz. And right now, I do not have any radiation oncologists, so that's the reason.
Well, what's wrong with Dr. Leo?
Oh, I still have to find out if he is available and whether he can fit me in his schedule and all that. So,
Okay, did Dr. Schmulowitz recommend you see Dr. Leo?
he didn't mention any names that day.
Okay, but did he recommend you see but you knew about Dr. Leo, right? Stanley Leo? I thought
Yeah, you mentioned about him, yeah. But as I said, my appointment was just 15 minutes to 20 minutes long, so we didn't have that much time to discuss about all other things. So,
all right, so
I got another.
So let me say this. This is true for the record. This is for the sake of the recording, and this is for the sake of everybody on here. Write your questions down on a piece of paper, such as, if I need a radiation oncologist, who do I see? Or do you think I need a radiation oncologist? Who do I see? That's the question. And you give that to Dr. Schmulowitz.
Okay.
He will answer every one of those questions before he walks out of the room. Everything you write down. Now, if you give him 20 questions, he may fumble through some of them, but he's going to say something. So you have to be respectful. But it bugs me when people come and say, oh, well, I didn't get the time with the doctor. We tell people all the time in AnCan, you can get that time with the doctor, write your questions down and be your own best advocate. And if there's something important and you've driven all the way from Rockford to Hyde Park or wherever it was, or downtown to see him, Hyde Park, if you've driven all the way to Hyde Park, he's going to answer your questions. And when you come in here and say, oh, well, you know, we didn't get to talk about the radiation oncologist, I want to say, guys, come on. You're not third graders. We've got to be our own best advocate. We can help you, but we can't wipe your bums. And that's what you've got to do. When you're going all that way, have your questions ready. Don't walk out with key questions not answered. Or say to me, well, I don't have a radiation oncologist. Well, you should do. And that's who we would say to you right now. You want a radiation oncologist and you're going to, and you're seeing Dr. Schmulowitz, go see one of the radiation oncologists at University of Chicago. There's a bunch. Who do you, David, who does your radiation oncology at UC? Oh, you go to the guy, you like the guy at Northwestern, right?
Correct.
You know, we'll come up with a guy. We'll come up with a guy for you.
Okay.
So you wanted time today to talk about MD Anderson. Was that it?
Just positives and negatives, if you recommend it or not. That's all.
We're not going to discuss it because it's not, you don't need that right now.
Okay.
So from our standpoint, we don't want to get into MD Anderson for somebody who lives in Rockford, Illinois. Okay?
Okay.
We're not saying yes, we're not saying no, we're just saying it's not a good use. What else is important to you right now?
Oh, that was my only question.
Okay. So you won't get to tell us about your appointment with Dr. Schmulowitz. It's lucky I asked. Okay, and you're on Lupron and he's put you on Lupron and you weren't going to tell us that either.
I was going to mention, yeah.
Oh, you were, okay. All right, fair enough, Len.
Rick, Carl is the only one remaining. I'm going to drop off. So if you and Carl want
to... Yeah, Carl, I'll thank you for staying so long. Carl, I'll definitely handle you. And Saranan, I don't know what to say. I mean, we can help you, but you got to work with us, man. You got to work with us because that's the only way we can navigate you. I just bear with me. I just want to look at your record because my computer shut down and I'm wrestling with, oh, gee.
You still there, Rick? Sharon, can you hear me?
Yes, I can.
Yeah, listen, I just want to recommend something else to you going along the same thought that Rick had told you. Something else you could try. I don't know if you have a patient portal where you can communicate with your doctor, but I found the use of the patient portal is very effective in outlining questions before you get to the office so you can get answers, get there. It's a better and effective, more effective use of time when you're dealing with that. If you do have the availability, take advantage of it.
Yes, I still need to set up that. You are talking about my chart?
Different organizations have different things, but it's a patient portal where you communicate electronically with the doctor and you can do it in advance. That my doctor loves that. Any questions I have, sometimes I'll have a lot of them. I send the questions in, and this way, when I come in for my appointment, my doctor has the answers for each question I have specified right down there, and it's had time to think them over and research them.
Okay, thank you.
And Shmulowitz is very responsive on my chart.
Good to know. Thank you.
You're coming up mute, Rick. We can't hear you.
Oh, there he goes. He will be back. Okay, David, it is either you or me who is in charge.
Go ahead, Jim. Keep going.
Oh, well, I don't know because I was off of it. Russell, you have your hand up. You're on mute.
Yeah, I have some questions, but they're related to, I think Rick would have to answer these, so I'll do it
okay.
privately, but, they're related to not using biclutamide before ADT, which I think, anyway, my questions are related, I think that I would address to Rick.
Yeah, okay. Well, he should be back here soon because he's probably rebooting. Steve, you have your hand up waving at us or what? Oh, Steve is, he waved goodbye. Oh, okay. And Richard left. Oh, Rick is back. I think. There we go. We hear you.
Yeah, my apologies. My apologies.
No problem.
I got kicked out again. All right. So, Carl, we're doing a quick intake on you.
Before you go there, Rick, Russell had a question for you. He had his hand up.
Yeah, go ahead, Russ.
I had two questions related to Joel, who lives in the Villages, and I lived in Florida, and I had a medical oncologist at University of Florida in Gainesville, not a GU, and he did recommend biclutamide before I reinstituted ADT.
Yeah.
But I'm feeling that there's, when you said Schmierowitz, you were disappointed. I'm just concerned, I'm not concerned, but I wonder if that incidence of the flare is so low that there's a trend for urologists not to use it. anyway, I don't know how to resolve that other than
Yeah.
questionnaire, but I have a feeling that more and more people are not recommending that. So that's my first concern. I don't have an answer to it. And my
So
second,
let me respond. Let's take one at a time.
okay, one at a time.
Let me respond to that. I think you're right. I think we see it more often. And I think it's probably especially remote when you're early on and you're post-surgery and the PSMA scan is clear and everything else. I just feel, why then don't you just give the first shot of Firmagon and switch to Lupron after that? And, why take the chance? I mean, yeah, we couldn't see anything. We didn't see anything in Saranan's back. But I guess I don't want to say I'm old school, but it does concern me that sometimes we just can't see the stuff. Now, the doctors can say now, well, the PSMA didn't show anything, so I didn't think it was necessary. And that would be a good reason. But I just prefer to see them do that. That would be my response, Dr. Russ.
Well, I don't know if there's no data related to how often it really occurs. But anyway, so my second question is related to Joel, who was on previously. I know he lives in the Villages, and I was obviously close to the Villages, but Moffat has, they have a cancer center, and it'd be a little closer, and I don't see any recommendations for that. And I'm not asking for you to trash them, but obviously.
No, I'm not trashing.
No.
They don't have.
Go ahead.
We don't think, and we've had people go to them, we don't think that their GUMOs are as good as Guanciale or Belusic.
Okay.
And that's based on people going to see them. I'm trying to remember the name of the guy.
Rick, I went to him.
Go ahead, speak up.
I went there, Rick, and I tell you what, I was so dissatisfied, and I was I was ready at my wit's end, and it's when Rick came up and Len with Dr. Guanciale, and I was hesitant to go there, but I'll tell you what, it was the best thing I did. I went there. In fact, I went there to try and prove him wrong, and I was so happy and ecstatic that I did meeting a doctor like that. When I was at Moffitt, I thought it was going to be the gold card standard. It was not only with the GU they had there, but with the nurse that the GU had. Other than that, yeah, it's a great hospital.
Okay. Well, that's for informational purposes. I have no allegiance to them, but it's like hard to believe that they're delivering that kind of care. So anyway, that's all.
So
I got it.
I'm just looking. Yeah, Zhang is the kind of the lead. Zhang and Pao Sang are the two guys. I think, Pao Sang's a urologist, and people like Pao Sang, but he's the chief of the department, but he's a urologist. The guy who is really the lead GU Medonc there is Zhang, and we've had people go to see him and they don't like him, and they don't like the treatment they get from him, and they're not happy. And what we know is that many people that we've sent to Dr. Guanciale love her. She has a great bedside manner. She was trained by Dr. O. She was at Dana-Farber and God knows where else. And that's why, and that's how we base our recommendations. So we would say she's probably as good. She's less than an hour away from Moffitt. The other is Dr. Belusic. He's further away, but that's Russ. That's why we don't send people to the GU Medoncs. because we don't have good feedback. Bob is not alone. We've heard this. If we've heard it once, we've probably heard it half a dozen times.
And I got to tell you, I thought it was going to be the world going there. I really, really did. And if I wasn't happy with Kwon, I was going down to see Dr. Belushi, but I would not go back to Moffitt. That's just me.
Well, that's why I listen in here. That's why I spent 2.5 hours here, because
yeah,
I'm not in Florida anymore. But you know, I would have thought, well, that's, you know, that's the end all, because I can't remember the article. It was actually, I first read in the Wall Street Journal that they were treating prostate cancer as the pesticide community treats that. You know, so I thought, well, wow, they're avant-garde. Anyway, so thank you.
Listen,
That's why I listen.
Dr. Russ, you've listened to us for long enough now. You know we push centers of excellence. We think the sun shines out of their garbage entrance, to use the analogy. We love centers of excellence. However, there are centers of excellence that don't have great GU med oncs. And we know how good Dr. Guanciale is, and we had heard great things about her. But when Len went down to see her, and Len came out shouting her praises, and then I had another doc, and then I met her at GU ASCO, and I said, we hear some great things, and she was cute and nice and appreciative. So we said, okay, we'll talk about Florida oncology, because we've got a great doc who comes out of a background of centers of excellence, and we trust her. And that's you know, how we develop most of our recommendations here. And so
And I'll
there
tell you,
are
Russell, if she wasn't as good as Rick is saying, I would tell you point blank, because I won't support somebody who isn't a quality individual, and she is quality. And if I wasn't going to her, I'd be going further south to Miami. That's just the way it is. But as far as Moffitt, I thought that was the end all. I will never step back. Maybe they have other parts of the hospital that are good for cancer, but their prostate cancer doctors, GU, forget it. It was horrible, and so was the nurse. And they were like, you know, you're going to do this for the rest of your life. And I was like, for the rest of my life? You're not going to talk about anything else now? This is it. Don't worry. And then I talked to them about diet. Oh, you don't have to worry about diet. You can eat anything you want. I was like totally dissatisfied with them. I mean, that's how bad it is. And I feel bad about that.
I'm going to give Dr. Russ the last word before we get to Carl.
Before I said, it's like a barking dog.
Well, you know, that's why I listen in. I'm learning like all you guys. I know the medicine, but I'm learning. Rick's on the ground, and you know, it's all about knowing. You can have all of the credits in the world and all the rankings, but if they're not good docs, they don't listen to you. They're not empathetic. Yeah, you go someplace else. So I just wanted to know why this major cancer center is so bad for prostate cancer.
But they're not alone.
Yeah, of course.
They're not alone. I mean, I could probably give you half a dozen that I can think of off the top of my head, NCCN centers that don't have good GU medical care. Indianapolis, Simon, not great. Vanderbilt, not great. I mean, they're not great. So we want you to go to where we know there's great docs. I mean, Masonic in Minneapolis is not an NCCN center. It's an NCI center, but Antonarakis is terrific. You know, we that's why we would send you there. And you know, the same thing. Why do I not want to discuss MD Anderson with Saarinen? Because he's not going to do much better than Dr. Shmulewicz anywhere. You know, I can't, if he doesn't like Dr. Shmulewicz, if it's a personality issue, I accept that, because not everybody gets on with everybody. And he may say, oh, we just didn't get didn't get on to get to, well, fine. Okay, then we talk about somebody else.
My question was, Rick, it was not about the med onc, but radiation oncologist. If it would be good at MD Anderson, that was my question.
But why go to MD Anderson when you've got really good people in Chicago?
Well, that was before I found out about Dr. Smolowitz. Yeah.
Yeah, and here's another question. Keep your care as best as you can in the same institution. The reason David Muslin doesn't do that is because he started at Northwestern. He had a very good radiation oncologist who he got on with at Northwestern. Then he switched because he had issues with the medical oncologist in Northwestern. He went to Dr. Smolowitz, and he's happy. He's got an existing relationship. Otherwise, he'd be seeing Stanley Liao as well. That's the reason why. And we don't want to mix these institutions up. You're much better off keeping everything in the same place, because then they talk to each other. There's a problem when you cross institutions. You have communication problems between the doctors. So we're better off keeping everybody in the same place. If I had to say Ray's still here, if I had to redirect Ray right now, I'd send him to Elizabeth Heath because she's great. She's the doc I would see at Mayo. I mean, you know, she's worth a fortune. And we've sent guys to Elizabeth Heath. They love her. So try and keep it all in the same place. So when you say to me, well, I'm going to go down to MD Anderson just to get my radiation. Why? We don't think they have. Yeah, they have good. We had somebody who went down to MD Anderson from our other group, and they weren't that happy at all. Yesterday, they came back in. Anyway,
Rick.
Carl, are you there? Yes. Carl Lieb, are you there?
I am here.
Okay,
I am
you're
here.
there, and thank you for hanging in. And I'm happy to talk to you. How old are you?
I'm 76, and Russell has his hand up.
And Russell, go ahead. Oh, Russell has his hand up? No, it's gone down. It's up. It's up. It's down. Go on. But you're muted. You're muted. I can't hear you if you're muted. Dr. Russ, you're muted.
Yeah, no. The hand was up. I thought I had taken it down. I'm done. I'm
Okay, you're done. So whoever told me his hand's up, he's done. He's finished. Okay, I'm going back to Carl Leib. 76. How do you pronounce your last name? Is it Leib or Leib?
It's actually Leib.
Leib,
Actually,
okay.
if you're in Germany, it's Leib. But in
I
the
know.
United States, it's Leib.
That's why I speak German. I learned German. That's why I immediately say Leib, but I'm going to say Leib to you. And I'm even putting in L-A-B-E by the side of it, so I know how to say it next time. Now, where do you live?
St. John, Indiana.
St. John, Indiana. I have no idea what part of Indiana that is.
30 miles southeast of downtown Chicago.
Okay, I do know where that is. That is near Chicago City. No, Michigan City, right?
Yes, that is correct.
Right. So we know somebody who lives in Michigan City. It's
That would be Jim Schrate.
Exactly. Is he who sent you?
Yes.
Okay. And how do you know Jim?
I don't. I followed a long trail of breadcrumbs until I got to him, and he sent me to you.
Okay. What year were you first diagnosed?
In let's see, July of 2025, last year.
Okay. And what was your Gleason score and your PSA level at the time of diagnosis?
Gleason 8, 4+4.
And your PSA?
At the time of diagnosis was
Yes.
29.
Okay, I like to hear that. I'd much rather hear that than what we heard from Ray, because it's much more in keeping with a Gleason 4+4. When people come in and say, "Oh, I had a 4+4, but my PSA was only 4 or 5," it gives me the willies. It makes me nervous. You have your hand up, Ray. Is it about Carlab or something else? You're muted. You're muted.
It's not pertaining to what you're talking about right now.
Okay, so I'll come back to you.
Okay.
I'll come back to you after Carl.
Just a quick one.
Okay, I'll come back to you after Carl. So how many cores were positive? How much cancer did you have in there?
They took 12 cores and every one of them was positive.
Oy, okay, we know where we're going with this. And which institution was this at?
It's called Powers Health in Munster, Indiana.
Okay, so it was local.
Local,
And
yes.
So now we know that you've got like 12 out of 12 or whatever it was, and you're a 4+4 and you're 29. Did you have that biopsy reread or not?
Reread, I did not, no.
Okay. What did they do any?
29, and then immediately I went on Orgovix and Extendi.
Okay, so hold on. We'll hold on a minute on that, because there had to be a reason for that. And the 4+4 and the 29 in and of itself isn't enough of a reason to stick you right on there, unless they were going to be doing some radiation as well. So
I've had 20 sessions of radiation treatment that concluded on January 13th.
Okay, so they said to you when they started you off, they immediately put you on Orgovix and what did you say?
Extendi.
Orgovix and enzalutamide. So they put you on Orgovix and then plus enzalutamide, and was that before the radiation?
Yes, sir. 6 weeks. I was on it for about 6 weeks before the radiation.
Right. And they gave you 20 sessions of radiation. And
yes.
Was that all to the prostate?
Yes, all in the pelvic region. The pelvic region.
The question is, was it all to the gland, or was some of that SBRT to the prostate? So did you have like 4 sessions of SBRT to the prostate and 14 IMRT, or was it all IMRT?
I do not know the answer to that.
Okay. Because I'm suspecting that what they did doesn't make a lot of sense, and I'll explain to you why. I'm suspecting that at 76, it makes perfect sense for you to go to the radiation route. Do they do a PSMA scan?
I have to ask you about this because I've heard of PSAs. I have all kinds of scans. I don't exactly know what is a PSMA scan.
Okay, it's a scan to see if the cancer had spread outside of the prostate.
Yes, it has.
And what sort of scan did they do? How did they determine that?
If I could, I don't know. I got papers scattered every place. They did a scan, and I know that it has spread in the lymph system and also at least one of the pelvic bones.
Okay, so there's one spot in the pelvis, and there are spots in the lymph system. And how many spots altogether?
That I do not know the answer to.
Okay, well, it's very important for us to know that. it's also important for us to know how they saw this, whether they saw this with an MRI scan or whether they saw it with what's called a PSMA scan, because they're different. So it's important for us to know what type of scans you had. And that should be in your notes somewhere. I mean, maybe you'll come back next week and you can clarify this, because all of this is important, is real important. 20 sessions of IMRT, 20 sessions of radiation is not enough.
Okay.
It would be fine if they were just going to radiate your pelvic, your prostate gland. But the fact that they put you on Orgovyx and enzalutamide means that they saw something more, and probably you were at least T3B. That's the stage, because you have to be T3B to get enzalutamide. So the fact that they saw this these lymph nodes and the metastasis, they're sort of going ass backwards. If they knew you were metastatic, then the Orgovyx and the enzalutamide would have made sense for a while, and then we would have gone back in, and you had less than 4 or 5 spots. Then we would have gone back in and talked about radiating the prostate gland. If they didn't think that you were extensive, they should have radiated the whole of the pelvic girdle. But to radiate just the prostate and to give you Orgovyx and enzalutamide is neither one thing nor the other. That treatment path doesn't make sense.
Yeah, maybe I didn't say this right, Rick. They radiated the whole pelvic region.
But they only did 20.
Only 20, that's correct.
It's not enough. I mean, normally if they're radiating the whole pelvic region, they would, well, unless let me say, unless they did not treat the prostate at all. Do you know if they treated the prostate?
I assumed that they did, but I meet with my urologist tomorrow. I'll find out.
Okay, so what we've got to find, so here's the thing. I've not ever heard of them radiate just the pelvis in a situation like yours and not the prostate. Normally they'll do both, and there'll be something like 45 treatments, or there'll be 20 treatments to the pelvis and some different type of radiation to the prostate, like brachytherapy or SBRT. And so you finish up in that sort of region of either 44 IMRT or 20 to 25 plus treatment to the prostate. We need to find out exactly what sort of treatment you had. If you had a PSMA scan, what that PSMA scan showed, how many lesions there were. Would you like me to repeat that so that you can make notes?
I wrote it down.
Okay, so we really want to know, because there's nothing wrong with the Orgovyx and the enzalutamide, but it's an unusual treatment at diagnosis. If they found that you were T3B, that would be normal. But if you were already T4, which you were, then we wouldn't expect to see the radiation so early. We would expect to see radiation, but normally if you're already T4 and they're putting you on doublet, they don't radiate the pelvis. So I'm trying to sort of unravel where they went with this. So you've been on this hormone therapy now for just over 6 months, and hopefully your PSA is undetectable and your testosterone's about 10. Is that right?
my PSA is 0.1.
Okay.
And
So
I'm not sure what do they call testosterone something else in these metabolic panels or?
No, it should be identified as testosterone, and it should be probably around in single digits.
All right, that's another piece of data I'm going to have to collect for you because I don't recall having a single number for testosterone.
Okay, they should be checking it, but there are some doctors who don't check it. So they may not have checked it, but they should be checking it to make sure that you are responding correctly. Okay?
Yes.
So if the guy says, if the doc says, oh, we didn't check that, you say, well, could you please make sure that my testosterone is at castrate level?
Okay.
Now, the fact that you're at 0.1 is a concern because we would hope you would be at less than 0.1 right now. So you got to be talking to your urologist tomorrow about why am I at 0.1. Secondly, you should not, your treatment should no longer be quarterbacked by a urologist or a radiation oncologist. You're with the wrong doctor right now.
Okay, what kind of doctor should I have?
You should have a genitourinary medical oncologist. That's a medical oncologist who specializes in the prostate. It's called a GU, genitourinary or GU medical oncologist. Do you know, have you been watching the chat window? Do you know how to look in the chat window?
I do.
Okay. Captain Jim, would you please put genitourinary in the genitourinary medical oncologist in there for our friend Carl? So I would say, if it were me, I'd be shifting my care as soon as I could to a GU medical oncologist, or we just say GU MedOnc here quickly. And I would send you up to the University of Chicago and Dr. Schmulowitz, who we've been talking about before.
Can you tell, can you possibly spell?
Yes, I can. Yes, I got you. I can. And hold on a minute. I don't want to kick myself out of the room again when I do this. I got a bit of a dicky keyboard here, and it's been giving me a hard time, and I need. So let me. Here's what I'm going to do. I'm going to. I'm going to put a link in for you. I'm going to put a link in for you for Dr. Schmulowitz, and I'm going to type it in. SCMULE, Russell Schmulowitz. So copy, and there's the link, and I will write it in for you too, Dr. Russell. You can, when you make the appointment, tell him AnCan sent you.
Okay.
Because he knows who we are by now, because we've sent a few people to him. And he also treats David Muslin and others. And Saranan went to see him last week. So there it is, Dr. Russell Schmulowitz. And we need somebody to take a good look to make sure that you're getting the right treatment. Probably are, but we want to know why your testosterone, why your PSA is not undetectable at this point in time. And if the urologist says, well, it's 0.1, the answer to that is yeah, but it should be less than 0.1 if I'm on this doublet therapy. doublet therapy means enzalutamide plus
two drugs, yeah,
plus Orgovix. Okay.
right.
The other question: do you have a heart issue?
No.
Well, the other question is why they didn't start you on Orgovix plus abiraterone, which is probably the better way to go. And then if the abiraterone doesn't work out, we'd switch you onto another drug. And probably we would have put you on darolutamide because it's a better drug and you're eligible for it than the enzalutamide. It's friendlier to you as a patient. So
Okay.
we don't particularly like Orgovix and enzalutamide. You can ask your doc why he didn't put you on Orgovix and darolutamide off the bat, but you can say even so, I've heard that Orgovix plus abiraterone is the best place to start. The reason for that is we're more likely to get some action out of darolutamide or enzalutamide after abiraterone than some action out of abiraterone after enzalutamide. That's why we sequence it that way around. And if you followed all of that, I'm going to have you moderate next week.
Well, I've got most of it, and if some of it shows up in the comments, that would be helpful, Rick.
Yeah, and this is all recorded. This is all recorded. It's still being recorded. You'll be able to listen to it, but it may not be uploaded in time for you before you see your urologist tomorrow.
2:30 tomorrow afternoon. I watched your last 3 sessions that you recorded.
Okay, so look for it on YouTube. It'll be on YouTube and without any of the comments in on it. It'll be on YouTube first. It shows up there before I even start working on it.
Okay.
I don't know that I'll have the blog post done by 12:30. That would be 2:30, 1:30, be 1:30 my time. I might do. I'll try and get to it quickly so the blog post is done and what have you. But what other questions did you have for us, Mr. Labe?
Well, the most important thing, I guess, is that I want to make sure I'm on your list so I get invited to the next meeting.
Oh, well, you don't have to be invited. Anybody can drop by and anytime. You don't have
I want your emails.
Oh, but you want our newsletter. Okay.
Yes.
Do we have your email address?
See, I thought you did, but I'm going to give it to you right now.
Well, you hold on 1 minute because I happen to have the screen up here and I'm going to see if we have you in the base, because if we have you in the base, then we don't need to do all of this. And it's telling me that we don't. So go ahead and give me your email address.
It's LAIB, my last name.
Yeah.
11588 at Comcast.net.
Got it. So LAIB 11588 at Comcast.net. I'll sign you up right away. And let me promote our Men Speaking Freely group, which is a great talking group to talk about everything and anything except your prostate cancer. So if you want to hear Dr. Jack postulate on all kinds of issues for quite a while, that's the group to come to. It's a very enlightening group. We don't record that group. It's truly a great group. We have 20 to 25 guys, different guys, every 2 weeks. Dr. John moderates it and Rich Jackson moderates it, and it's a wonderful group, and we recommend everybody try it at least once. And David Muslin occasionally also does that. So I'm going to sign you up for that one, but you don't have to come. You don't have to come to any of our groups.
No,
to be honest.
I probably will, but I can match you guys story for story.
Okay. Well, hey, you sound like you're perfect. You're perfect for for that Men Speaking Freely group. You're going to be right in there. Now, anything else? I've got your email address. Is there anything else that was on your mind or that you want to ask us about before you see the doc?
That's just a wild question. I'm waving my hands, but you can't see me.
No, I can't.
All right, I know. I'll get that fixed. I don't know why it's not working. You guys probably know about this, but I just read about it. Cancer cell sequencing and cancer organoids. Are you familiar with this?
I don't know about cancer organoids, I'm afraid.
What they do is take samples of your lesions and they grow them in test tubes, maybe 100 of them. And
I do know about that.
And they then test various medicines.
Yes, I am aware. I am aware. And in fact, I'm trying to remember the name of the company. They came to us last year and they wanted us to work with them, but we didn't really feel they were ready for prime time. And I can't even, I'm talking to you, so I don't want to look for it right now. But the answer is yes, we're aware of them. Here's where we would come out on this. Let me first ask you, have you had any genetic testing?
Yes.
And did it show anything?
No.
Have you had any somatic testing? Have they actually tested any tissue, any of the tissue that they got in the biopsies?
Not that I know. I'm not sure I understand the question, but I think not.
So the genetic testing tests to see if you've inherited anything from your parents. Do you have a history?
That's my no. That's my no.
That's your no. And do you have a history? Do you have a cancer history, Carl?
No.
In your family?
No.
No. So
I'm surprised.
At that. Now, the next thing we can do is test your cancer itself to see if there are any mutations in that you've made in your own body. And that's called somatic testing.
Okay.
And because you had a bone met in your pelvis, your urologist should have done that because that's the guidelines call for it.
Okay.
So if you want to keep laying it on him, you can say, how come you didn't do somatic testing? We cannot do that from your blood at this point in time because there's probably too little in there. We don't know, but I'm guessing there's too little. So we would have to do it. We'd have to test from a sample from your biopsy samples. But the good news is it's within 6 months, so it's probably not going to be that accurate. I probably would not let them do it. I'd wait until you've switched to a center of excellence and you're there.
Okay. But
we need to do that. Now, that's the sort of thing that will cover when you get to a center of excellence. And it's not surprising your local doc didn't do it, even though it's in the guidelines. What you're talking about, I attend a Wednesday session most Wednesday mornings, and there's a guy in there in California who does this testing that you're talking about, where they will grow tissue and they'll see which treatments are best suited to your cancer. But in prostate cancer, we have so many ways right now to get the cancer to respond, that we don't need to get into these more exotic treatments. There are many steps to go through before then. And if you wanted to do that, we can hook you up with people that do it. Like I say, I know this guy on my Wednesday morning. He's in Northern California. There's the other company that came to us. We got different companies, but it's a little too exotic in our view for where you are in your treatment.
Okay, I don't know that it's approved anyway.
It isn't. It's
Yeah,
not
I
FDA
don't-
approved yet.
Yeah,
But
I
if
don't
you
think
want
that it is.
You know, if you want to throw $5,000 or $7,000 at it, it can happen.
Okay.
But we'd say you're better off saving 10%,
Throwing it to you, I know.
throwing that at us than,
I got it.
you know, because it's too exotic, and we know the people. We do know the people.
Okay.
What else did you have to ask?
Rick, that's all I got. I think we've worn out our welcome with you.
No, I'm cool. I'm cool. And I've got to answer a question for Raymond, and I got to find out what Graham wants because he came in really late. So come on back next week. And and Jim Marshall wants to know, are you a veteran?
Oh, Jim Marshall. You talk about stories. All through high school, I had a locker next to a guy 4 years named Jim Marshall. And I was looking at him to see if that might be him, but it's definitely not him. So, yeah. Now, I spent 6 years in the Army Reserve. I am not a veteran.
Oh, yes, you are.
Am
You bet your sweet ass you are.
I never deployed.
It doesn't make any difference. Trust me. Trust me.
Let me just say this. You can trust Captain Jim. He finds money where nobody ever thought they would seek it. They would find it. He knows how to find money in the darkest of places. So Jim Marshall,
Right.
I am going to sign him up. I'm going to sign Carl up
good.
for your veterans. Okay. I'll make
Yes,
sure
sir.
he gets into your veterans. He missed Veterans Speaking Freely because they're closing out right now, but we'll sign him up for that too because they'll like to hear his stories. And go
Right.
to the next group. The next time there's a veterans group, go into that group, and Jim will straighten you out on what we can get you and what we can't get you.
Thanks, Jim. I just assumed that I wasn't because I never deployed.
It depends. It depends. Okay. There is a good chance.
All right.
Okay. Now, here's what we can do. Let me talk to Raymond quickly. Let me talk to Graham quickly. And if Jim Marshall is up for it, I'm going to give you the room right now so you and he can talk if you want to do that. But let me.
I'll hang in there. Yep.
Okay,
sure.
you hang in there, and then the two of you can talk and sort it out. Raymond, please go ahead because you had your hand up.
Yeah. No, I just want to tell you, Rick, first time I've been in here, and I really appreciate what you do. It's been, I don't know how you do it, to be honest with you, 3 hours talking like this. I enjoy your passion, and if you could read scans, I'd come to you. But,
no, unfortunately,
I got a choice between, I don't really, that's really all I wanted to say. I appreciate you letting me in.
No, and thank you for saying
what I've
that.
got.
And I'm sorry, we're not fans of a lot of people like him. He knows how to sell himself. He's got a big following. He just doesn't do it for us. And the reason, Raymond, is not just because he's not. It's because I've seen too many people who have not been treated right, and it's been too late to salvage them. And I've lost friends that he's treated, and I don't feel we needed. They may have died anyway. I think they died sooner than they needed to, and people are passionate about him. It's kind of like proton beam. You get these people who love proton beam. There's nothing better about it or worse about it, but they want proton beam, and they they will proselytize for it. And Kwon's guys are the same, and it isn't. So he's not our flavor, but Dr. Heath is.
Oh,
and Dr. Sartor was too. But Dr. Sartor, I knew Dr. Sartor wasn't going to last at Mayo. For the same reason you're thinking and I'm thinking, and I was right. I think Dr. Heath will stick it out because
Dr. Heath is two floors down from. If I have any peeing problems, I believe Dr. Kwon will take me there. He's had 35 years of just nuclear medicine. That's all he does.
Well,
he's dedicated to it. So he's read a lot of scans.
No. He's not a nuclear medicine guy. He's a urologist. Dr. Heath is not a urologist. Dr. Heath is a medical oncologist. She's who you should.
Okay, that's a good question. Why do I need a genital urinary if I don't have any peeing problems?
Because for peeing problems, you need a urologist. For peeing problems, let me tell you who you need for peeing problems. Dr. Kwon. Dr. Kwon. That's his expertise.
He doesn't do that kind of stuff.
That's right. He does stuff.
He does prostate cancer.
But that is all part and parcel.
That's all he's ever read.
Okay. But
I'm just listen,
I don't want to go there with you, but we know what the doctors are trained for. The doctor the doctor who is best trained to treat you right now is a genitourinary medical oncologist. And that's what Dr. Heath is.
Would you have me on triplet therapy?
I'm not a doctor, and I would probably not have you. And I don't know how many lesions you have, but from what you told me, if you had less than 5 lesions, the answer is that the guidelines don't promote that, and we probably would have said, talk to your doctor about getting off it. So I don't know.
Why don't we treat prostate cancer like we treat any other cancer? That's what I don't understand. Like we treat breast cancer, like we treat liver cancer.
Why don't we treat it? Okay,
Dr.
Russ, you had your hand up. Would you come in and help me, please?
Yes. Listen, we've been at this for 3 hours and 18 minutes.
Yeah. I'm sorry.
Okay, Raymond, you have overused your time, and we are not here. I mean, Rick is not here to convince you, nor is AnCan. And it looks like you're pretty settled in your ways. And I would say we're not here to convince you. We give advice, and I see a tremendous amount of resistance. So I think you need to step back and listen to more of these recordings and just give Rick a break.
No, really. Just don't misrepresent the care I'm getting, because that's not the care I'm getting. I don't get choline scans every time I go to him. I get blood work every 3 months. How many people are getting
You are on my case. I never even raised choline scans. You came into this group today, Ray, to chastise me about how I speak about choline scans. That's why you came in. And I'll tell you something. I would never recommend anybody to get a choline scan today unless they were seeing Dr. Kwon, because he's the only person that I know that still relies on this. Everybody else uses more up-to-date technology. And why use a choline scan when you've got PSMA scans out there? I really don't want to discuss it anymore. You're going to do what you do. I told you, if you want to get the choline scan, go to him. But don't tell anybody else to get a choline scan.
It's not the main scan. It's not the number one scan.
I don't care if it's the
it is metabolic, and it will show things that a PSMA will not show if it's metabolic.
Well, I can't argue that. I'm not going to argue that with you. And
you're arguing this thing, and you just really need to give it up a little bit, Raymond. That's not what this forum is for.
Okay, I'm sorry.
I've been to Hilton Head. Nice people in Hilton Head, but you're not it.
I just thought, my point is, I thought Dr. Kwon was misrepresented a few weeks ago when I was listening to this.
I know you did.
They came to here in 23.
I don't need you,
16
Raymond.
lesions, and then he comes back 2 years later. He's wanting to get off a Lupron. And you're telling him to go see.
I don't need you to defend Dr. Kwon. If that's why you came in here, I'll tell you what I'm going to do. I'm going to ask you to leave. I am not. I don't give a shit. I'm sorry I said that I'm sorry I said that, but I'm glad we're having this discussion. I'm going to leave it on the record. You didn't come in here to talk to yourself about yourself. You came in here to defend Dr. Kwon. And you know what? I wrote that to my organizers an hour and a half ago. That's not what this forum is for. It's not to defend Dr. Kwon. I'm entitled to my opinions. You're entitled to yours. I'm not here to defend Dr. Kwon. I don't like the way he treats, but if you like it, it's fine. If you want the right doctor for you at Mayo, that right doctor, the correct doctor, is Dr. Elizabeth Heath. I'm done. Graham.
Okay. I agree. Okay.
Graham.
I think you're taking me on in this place, Raymond. And we've listened to you long enough. We've listened to you long enough, and I listened to this many times. This is not the forum for what you're doing. Sorry.
Okay. Good luck.
I wish you would have said to me from the beginning, because we could have saved ourselves a lot of time. I love my doctor. I'm very happy. I don't like the way you talked about Dr. Kwon, and we could have agreed. Okay. Don't come in here and try to defend him on the basis of, and you know what? In our view, he's overtreated you. It isn't the right treatment. You didn't need chemotherapy, but that's what he does. And I've seen him kill people that way. And that's why I don't like
it. Off from 16 lesions in 2 years. He had him talking about getting rid of his Lupron. How explain that to me? I don't know.
I don't have to defend. I don't know who you're talking about, but I don't have to defend how other doctors treat.
All right.
You love your doctor, keep your doctor. Have fun.
That's right.
Okay.
I don't know who had 16 lesions. I don't know.
That was your friend.
Okay, guys. Okay, guys. I am taking command of the room.
Graham, can I help
you?
Yeah,
hi.
You hear me?
Yeah, hi, Rick.
Yeah.
Actually, I have some really good news. It's been since April that I finished my radiation after my prostatectomy, and things were looking pretty grim. And after the prostatectomy, I had a Gleason 4 + 5 = 9 and a PT3B-N1. Anyways, my PSA dropped to undetectable. I'm not sure what all did that the most, the radiation or the Orgovyx and abiraterone. What I haven't had is a bone density scan, and it's been 10 months since I was on Orgovyx. Is that unusual?
Yes, it is. It's not unusual. I know what you. It's not unusual, but it's not right. You should have had it.
Okay. Well, I have a meeting with the radiation oncologist tomorrow on Thursday, and so I'll bring that up.
Okay. So let me just because I've now got your record up, and I now know who you are. You're in Ottawa, correct?
That's right.
Yes. So let me just recoup and update my record here. So we're here now at 126, and you now had radiation to the pelvic bed
and to the rib.
And you're on Orgovyx plus what? Because last time you were only on Orgovyx. You needed
right. We added abiraterone.
Okay.
And you guys had actually recommended me getting a second opinion. I did do that second opinion. You don't usually do that in Canada, so the radiation oncologist got kind of, he got a little like antsy right away. But I did see the oncologist, and he was like, "No, go to a doublet therapy, not triplet therapy."
Yeah,
And how many nodes altogether did you have on the PSMA? How many spots altogether did you?
Yeah, I don't know.
Okay.
There was several,
and
but
who gave you the second opinion?
it was an oncologist.
Just a GU oncologist, medical oncologist, or just a general oncologist?
Well, he would be he said if my PSA starts to rise, I'm the next guy he sees. So that's all I can tell you.
But that's fine. But you know, we don't think it should be a general medical oncologist. It needs to be somebody who specializes in prostate cancer. Was he in Ottawa?
Yeah.
What was his name?
Ooh,
because there is a good guy in Ottawa. That's what I'm asking you, because
yeah, his name was he was Dr. Basse.
There's a guy in Ottawa who's a GU med onc, because they're hard to find. Oh, Michael Ong is the guy I'm thinking of.
Is that, did you say Long?
ONG.
Oh, okay.
Michael Ong, and I'm going to put him in the chat window. And if you do need to see somebody, that's who we would suggest you see.
Okay.
He's one of the few GU medical oncologists in Canada. There just aren't that many.
Okay.
Okay. And so you're still on the abiraterone, correct? The doublet?
Yeah.
How long did they say you're going to be on there for?
2 years.
And your PSA is undetectable, correct?
Yeah. Less than 0.008.
Right. So let me just say that's what we would expect.
Yeah.
That is the normal kind of average normal response. So so you're responding just the way you should be. This is not a remission, as we said. I don't think you were here early on, but it's exactly how you should respond, and it's great. It's it's where you want to be, and the question is going to be what will happen at the end of the 2 years when you come off.
Yeah. And yeah, whether they're going to let me off, and maybe they won't, because I'm only 64 going on 65.
Okay, but what do you mean if they would let you off? They're not going to keep you on the
they won't?
Is somebody telling you you're going to be on this for the rest of your life?
No, I'm not at that point. I'm just thinking maybe they might. So yeah.
Okay, well, I can see why, because here's an issue that I'm looking at here. You say you're T3BN1, but your PSMA showed pelvic nodes, bladder, neck, ribs, and seminal vesicle invasion.
Yep.
If that spot on the rib was confirmed as prostate cancer, you're not T3B, you're T4.
Okay.
And you need to know that. If you're T3B, then the future of your treatment is going to be different. And we would say, yeah, you should be on those 2 drugs, which you're on, and you'll be on it for a couple of years, and then you'll come off. Now, if you're T4, we might expect the same thing, but there are some doctors who might say, no, we'll never take you off. So if you really had spots on your ribs, it's important to ascertain that. But right now, I don't see you. How are you managing, by the way?
Great. I'm doing really good.
Okay.
Yeah.
All right. On that note,
I did have one thing to say though.
Yes.
I was cycling on and off of the abiraterone, because initially when I went on it, my liver enzymes shot up, and then they had me stop, let the liver enzyme go normal, put me on half dose. Then they shot up again when they tried me again. I went back down to half dose, stayed on half dose for a couple of months. Then they said, let's try 3/4 dose. And that's where I'm at. I'm on 3/4.
Yes.
Okay. So, Jim, you want to say something on that?
Yes. Anyway, I did the same after 2 months. Okay, the liver revolted, so they dropped me to 3 pills, and I was on it for 5 years. And I'm a T4, and I'm now on a 3.5-year treatment holiday.
Okay. You were on for how long? 2 years?
5 years of
5 years?
treatment and 3.5 years of treatment holiday.
Okay.
No drugs at all, except I'm essentially 81 plus, and testosterone is gone.
Okay. Are you on the drug holiday right now?
Yes, I am.
Okay. Were you feeling like,
PSA is 0.09.
yeah, were you feeling run down at all when you were on?
When I was on it for 5 years, I was exercising every day,
Yeah, I do
eating right,
exercise. Yeah.
and I tolerated it very well. It did not hardly slow me down at all.
Yeah, that's what I'm finding. I'm exercising.
Right.
Yep. Yep.
So,
Yep, you got to
Graham,
do it.
I just want to ask you: Are you taking the abiraterone an hour before you eat?
I take it first thing in the morning, and then I wait like at least an hour and a half.
Right.
Oh, okay. And you're pretty religious about doing that, correct?
I'm now very religious. Since it failed a couple of times, you better believe I am.
Okay, because
I did the same.
Hopefully the doctor explained it to you, but if you eat too soon, you get too much abiraterone in your body.
Yeah. I mean, since
All
I'm
right.
doing well on 750 now, I'm thinking, on Thursday, should I ask him to try the full dose again? But then if I go off, I'm off for a
Well,
few,
here's what you might want to ask him to do and see how you do on it. Ask him if you can go to quarter dose with a low-fat diet. All right?
Yeah.
So ask him if you can go to 250 a day at the same time as eating a low-fat diet. So you don't have to get up early. It's easier on you. You can, and you have like oatmeal with low-fat yogurt or, something like that, because that is the alternative dosing.
Okay.
And see how you do with that.
Yeah.
And that's equivalent to a full dose.
Okay.
So ask him about that. And please try and get here earlier, because this meeting started this is the Tuesday meeting, and the Tuesday meeting starts 2 hours earlier than the Monday meeting.
I get the email for the intermediate as well. So I looked at the intermediate and like, oh yeah, it's like starts at 8 Eastern. Like, oh no, it doesn't.
It doesn't on Tuesdays. It starts at 6 Eastern on Tuesdays. And with that, I got to speak to Muslin. So I'm going to turn off the recording.
Thank you, Rick.